Turn on. Oh. Good morning, and welcome. Welcome. So we are starting. I'm greatly honored to welcome you to this conference. I must say that I'm really impressed by the enthusiasm and the turn-up. This was not my expectation. Let's clap for ourselves. Exciting also. Many of us have been on Zoom for 2 years. We have not been seeing each other. Some people have seen. I last saw them when they were a little bit younger. They have gone some gray hair, but it's exciting to be back. Thank you for the science. Without science, we wouldn't be here. So I'm going to give a brief welcome. And after that, we are going to have a short video message from Dr. Soumya Swaminathan, the Chief Scientific Officer at the WHO, who is also the Deputy Director General in the WHO. So she will be giving us some opening remarks, and then we will be having other presentations. I'm Professor Pontiano Kalebu. I'm the chair of the Scientific Advisory Board of the Global Health Network. I come from Uganda. I'm the director of the Uganda Virus Research Institute and also director of the MRCUVI and London School of Hygiene and Tropical Medicine, which is part of the London School of Hygiene and Tropical Medicine. And I'm a professor of immunovirology at the London School of Hygiene and Tropical Medicine. It's really a pleasure to be here. I welcome you to Cape Town. I welcome you to Africa. So I'm really welcoming you and greeting you on behalf of all African partners present, as we're your hosts. And as I've been part of this from the outset, as chair of the Scientific Steering Committee, thank you for traveling so far, and I'm sure it will be worth it. It's really a unique opportunity and a unique conference because we're gathering not to share results like many other conferences, results from one disease or two diseases. This is different. We're here to share how we do research, how we build our teams, how we transfer our know-how and build research careers and systems for research. When Trudy and I were first working together over 15 years ago, we were setting up the EDCTP networks of excellence. And these aimed to share research excellence between malaria, HIV, and TB, and to connect centers with high and low experience. The old approach of capacity development then was to teach sites to collect data that was taken elsewhere. But we needed something different. So this began simply as a resource center for those wanting to undertake quality research, but with no access to training and tools, as they were not based in the major funded research centers. It's now 10 years. We're here as the Global Health Network community, and we're together as a family. A place for sharing research know-how, generating and sharing those tools and training, so everyone has access and can lead their own research. This conference is so important as we're celebrating a decade of the Global Health Network and to take it forward together for another 10 years. There's an important new model we want to develop as we work together. This is the decentralized open franchise that enables federated and scalable leadership across the global south, taking this all to scale and using what has been learned about sharing knowledge and delivering skills. Of course, maintaining trust and quality is very important and has been achieved through reliable training, the tools that we have, the templates for research teams, so that we deliver through regionally based activities and also using online approaches. Each region and country hub can be autonomous, and this is the way we are functioning. Each region and country hub to be autonomous, win funding, and address their research systems and knowledge gaps. But they are all connected as a global health network, and so can use the same and shared processes, tools, and standards. This is what we want to achieve, and this is what we're aiming for. So I welcome you, and I hope you'll enjoy the next 2 days. Make the most of this opportunity we have of being together, and congratulations to the Global Health Network for the 10 years and all the achievements. I cannot end without thanking my friend and colleague for more than 15 years, Trudy. Thank you for the hard work. I think your smile has also done it. Always smiling, welcoming, and you can see the results of your hard work. Congratulations, and your team. Thank you. So now, I think, do we have the video? Let's have the video, brief video, and we'll continue with opening remarks. Video, please.
Hello, greetings from the World Health Organization. I'm Soumya Swaminathan. I'm the chief scientist, and it gives me great pleasure to say a few words to you today, though through video. I'm very happy that the Global Health Network has recently been designated as a WHO collaborating center because of the shared goal of addressing inequity in where research happens and who benefits from the research findings. It is a unique facility that drives collaboration to improve health outcomes through new evidence. And this is done by sharing research skills and know-how between different disease areas, organizations, and across geographies. The Global Health Network has worked in close partnership with WHO from when it began in Africa, and this conference celebrates 10 years of its existence. It has become a vast, open, thriving, and connected community of practice that is trusted and regarded as a source of reliable knowledge, training, research tools, and methods. And it's generating evidence, it's fostering research careers, and building lasting, capable, and internationally competitive teams in the world's most underserved regions. It is used by many hundreds, maybe thousands of healthcare workers and research teams. They access resources and skills online and in their workplaces. And through this, they have formed new collaborations and generated high quality evidence that is changing the patients' lives. And I think without the support of this kind of a network, the Global Health Network, they would not have had this ability or access to such support, because when you need it, then there is a place to turn to get it. The founders have shifted the leadership from the global north to a novel, decentralized, federated partnership across Africa, Asia, and the Latin American countries to further drive South-South knowledge transfer to increase research outputs and the transfer of evidence into practice and tackling local health priorities. The Global Health Network works closely with WHO to connect research with healthcare delivery. The designation of a WHO collaborating center will enable greater impact of the work being undertaken with the Research for Health team and TDR working along with the WHO regional offices and the TDR regional training centers. Together, we are working to ensure that there are active research capabilities in every healthcare setting, as this is crucial not just for tackling the everyday disease burdens, but without such abilities in place, when new pathogens emerge, firstly, they can be unnoticed and spread. And secondly, there will not be the local skills to spot and understand the threat and to respond to it. With successful scalable processes to embed these skills locally, WHO is very pleased to be working with the Global Health Network. We have recently set up the mRNA Technology Transfer Program as an example again of leveraging these South-South partnerships and capacities, knowing fully well that given the new technologies, given knowledge sharing, data sharing, making some resources available, that a lot of innovation in the future is going to come from the Global South, and we are there to enable that and make it happen. So I'm very thankful for this partnership and for the collaboration with WHO. Thank you.
That was one I didn't work out where the button is. Where's the button, Bonnie? Is the mic? Yes, it's perfect. Well, thanks everyone. Look at this lovely room full of people. It's just so great to see everybody here. Thanks for getting into the room on time. That was a perfect start. Ponciana, thank you for your remarks. And please pass our thanks back to Soumya. That was great to have her welcome us. So here we are, coming together after, well, it was 10 years, actually 3 years ago, but apparently there's been a pandemic or something that's kept us apart. But you know, this feels a much better moment to be here together because we've got so much to celebrate this few days together with the 10-year anniversary, but also with the setting up of the Global Health Network, Africa, Asia, and Latin America. So that's the exciting, exciting moment. So the aim today and tomorrow is to bring together researchers from all stages of their careers. And we're going to hear from people today and tomorrow that have maybe not even traveled before, never been to a conference and not presented their work. And they're going to be speaking here alongside some legends that I know you're all excited to hear from as well. So I really urge all of you to take the opportunity we have of being together. During the coffee breaks and at lunchtime and this evening, don't talk to your colleagues or the people that you know well from before. Please sit and talk to somebody you've never met, you've never worked with. Make sure this evening you talk to some new people and let's really see what we can deliver from this time together. When we advertised this conference for abstracts, we've had over 900 abstracts submitted, and it was a very overwhelming but lovely challenge to go through those and select the talks. So we have a really packed 2 days, and it's a very deliberately set up. We have no parallel sessions. We have this beautiful room, and we're all going to be here together. So please come to every session. It's not the sort of meeting to do side meetings around it. We've planned plenty of time in the day and in the evenings. So come to every session, listen to your colleagues and enjoy learning. You know, we're deliberately mixing up diseases, types of research and types of organization. So, so please come and attend everything. I think the other things I have to give, I've got a few housekeeping pieces to give you. But there's also some really strong outputs and important results that we want from this conference. As Ponciano described, this isn't a normal conference where we're just presenting results of our studies. The idea is that every talk you're going to hear and the posters in the hall are all around how people did their research or how they brought their networks together or how they solved a problem in undertaking the evidence they were trying to gather. This is all about trying to place research in every healthcare setting. And so we want some really strong outputs. And so each session will be focusing on seeing what they can draw together from across the different talks. Over the whole conference, we're going to try and draw that together. And we have a unique opportunity PLOS Global Public Health are going to do a special edition on this conference. And so there's an opportunity to publish and pull all those together. You can contribute. There's posters everywhere, and it says in your folders about how you can join up online. And so you can add your recommendations. We've got as much time as we can squeeze in for questions in the science sessions, but it's a bit tight because we wanted to maximize the speakers that we had. But do contribute. If you had pieces of your methodology or know-how that you want to share, please make sure you do. So lastly, for the housekeeping, obviously no fire exit, but it's quite clear how you get out if it all goes a bit wrong. We're all experiencing the load shedding. Hopefully, if we have any, it will be really seamless. There's a generator and you won't even notice. The most important thing the next 2 days is timing. Please, please, please use the exercise of jogging to the coffee break and back again. Listen to the marshals who are moving us around, and please be seated. I don't want to have to shorten any of the speaker times because we're taking a long time to move around. So please, 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 it was perfect. Everybody got here for 9:40. It was great to start on time. So let's keep doing that. And lastly, we've got, such a beautiful setting, and we're going to do a group photo, which we can't miss, can we? At the end of the day. So after the last session, we'll meet on the steps at the bottom. So that's all I've got to say. Thank you again for the journeys you've had to get here. I know, when we planned the conference, you could fly from Brazil to Cape Town, not at the moment. So the journeys some of you have been phenomenal, I know. We really appreciate you coming and taking part. Enjoy it, meet new people, form new collaborations, and do more research with each other that you might not have done before. So I'm delighted with the opening session we have today, and I'm going to pass to Lola Mngong to chair the session. Thank you, everybody, and enjoy it.
Good morning. Oh, is it on? Do I touch something? Okay. Good morning, everyone. It's an absolute pleasure to be here and to see all of you. My name is Lola Mngong, and I'm with Amref Health Africa. So first of all, let me thank Trudy and the entire team from the Global Health Network. It's been a fantastic journey prepping for our first session this morning. And I'm particularly pleased to chair this panel with really brilliant scientists and researchers from across the world. And they'll talk to us about their work and their contributions to fostering leadership and building lasting, capable research teams. And the way our panel will work is that we'll start off with a plenary talk, if I can call it that. And that will be from Dr. Varsi Morthy. And he will speak on the needs-driven research in underrepresented populations, which I think is quite important and very critical at this time, particularly coming out of a pandemic. And then following his talk, we'll hear from 4 speakers. Unfortunately, one of our speakers couldn't make it, and that's Miracle Adesina, but we'll still hear from 4 speakers just right after Dr. Varsi's talk. So I want to adhere to time. Trudy was very clear about that. And so without further ado, I'll welcome Dr. Varsi. Dr. Varsi is from WHO. He's an infectious disease physician and immunologist. Welcome, Dr. Varsi.
Thank you so much, Lola, and thank you to Trudy and the team for inviting us. We're here from WHO, from the Research for Health Department, to show our full support for this conference. And I can't think of a conference that I've been happier to attend. I spent yesterday going to the symposia, practical, needs-based research, with clear outcomes for populations around the world. So in this talk, I'm just going to go through some recent developments at WHO, which is not telling anybody what to do, but it's sharing some framing which we think is really directly relevant to the conference. This is one slide that shows the many, many global initiatives that have been set up. And if you go back to the beginning of the MDG era, this was in a way the golden period for setting up some of the very important global initiatives, the global funds, the Gavi, UNITAID, many others. And I think everybody would agree these have had a major positive contribution for health around the world. We have seen childhood mortality, for example, as one of the indicators, drop from about 13 million a year to less than 6 million a year. So just in that indicator alone, many millions of children, and a big contribution from this type of big global initiative. But what we've seen more recently in the SDG era is a leveling off of the development assistance for health. And I think a general understanding that we still need these big global initiatives, but we also need to support needs-driven research based on an understanding of what the beneficiaries in communities, in countries around the world need. And that really is much of the focus of the rest of my talk. There are a couple of initiatives over the last few years within the WHO framework that have sought to understand what people like you doing the important work in the field say about the way that the global system has been functioning, what has been working, what has not been working. There was something called the Global Action Plan within the SDG framework, which was bringing together all of these big multilateral initiatives and seeing how they can better work together to deliver impact on the ground. And as part of the research accelerator of this framework, we had a meeting in Rwanda where we invited many of the leading figures within ministries of health in low and middle income country settings. And we asked them how it had been working for them. And they said that still the situation for them is that they tended to find that the global agenda setting dominated over national research agendas, even though there are national research agendas that have been set in most places around the world, that there's poor alignment between the way that the international donor funds are programmed related to national health priorities. There are gaps between the knowledge generation and policy uptake, and access to innovations and scaling of innovations is not really adequately embedded into the pathways. In the more recent clinical trials resolution from May of this year, we have had a recent public consultation where we received many inputs from stakeholders related to the clinical trials work. And one of the streams that we heard from them was that there, as everybody knows, is a major gap still in LMIC capacity support. There is some promising developments in moving towards truly equitable partnerships, but we need to further support these, and we need a greater focus on needs-driven research, which is explicitly supported in the resolution. We need greater collaboration and coordination to align initiatives, and we need to think beyond in the drug and vaccine development sphere, simply licensure to ultimately impact, including affordability, availability, and suitability for populations. Some of the work has already raised some proposals for, how can we move to more country-led forums to translate evidence-based innovations that you have all identified to scale? How can we more drive decision-making to countries and regions? And we've seen beneficial examples of co-funding with grand challenges, for example, and we would like at WHO to see this go much further. How can we again look at better horizontal scaling, by which I mean there are many projects that have taken innovations identified through to scale up at the pilot or the district level, but we don't have a good system to then further scale those to really achieve impact at very large scale. And equitable access. Everybody saw the failure that happened with pandemic, with equitable access to COVID-19 vaccines. We still live in a situation where essentially access to new innovations like vaccines is more based on your financial ability to access those interventions rather than the need. And we clearly need to move beyond that. This is a graphic from one of our living guidelines at WHO, where what I wanted to highlight here is that we only have a few areas where we tend to have strong recommendations either for or against. And this means that in those areas, we have a high quality of evidence. And if you look at the research that underlies these areas, it was generally from just a few large adaptive platform trials. And there, by contrast, there were 18,000 roughly COVID-19 clinical trials, 18,000, which massively displaced trials for other areas. And what we have seen is that most of these were useless. And I say that in maybe what sounds like a provocative way, but it's a fact. Most of them were useless. So we need to really work on this. This is a publication from the FDA where they reported that 95% of randomization arms in these many, many thousands of trials were designed to fail. Even before they completed, it was clear that they, from their design, they were not going to lead to useful information. So we clearly need to work on not only more trials, but higher quality. There are a number of areas that I think have come out of previous work that point to some big themes that people agree that we need to work on to better link the resources to ultimately impact. And one of them is prioritization. And I think that goes back to the title of my talk. How can we have prioritization of the research that occurs, of the resources that are allocated, ultimately linked to what the beneficiary populations are calling for? And I think we still have a long way to go to get there, but we have some good examples of success that we can build on. Then there is a lot of work that is going on through the Global Health Network and in other areas for quality of research, quality of data, including around standards and interoperability, which is very important, and embedding data sharing all the way through the research cycle from the design through to sharing will have massive impacts if we can get there. How do we translate, and then how do we better? You will see all the way through my talk, there's collaboration and coordination everywhere, because from what I've seen, with a big increase in resources in a lot of areas, what is really lagging behind, and again, the Global Health Network has a role, is how we do better in terms of collaboration and coordination. The clinical trials resolution is calling for us, while we have guidance that's available for individual trials or research, what we don't have is an overall normative guidance framework for how donors and member states can improve their research ecosystem. And we've been asked to develop this for clinical trials. Our focus in WHO is not at all restricted to clinical trials, but the scope of the resolution is clinical trials. So we will try to keep in mind as far as possible, making it more broadly applicable than RCTs. And we're going to be going through a big consultation process with all of the stakeholders about the pillars that we need to agree on for this normative guidance on ecosystem strengthening. And where we'd like to get to is a sort of an M&E framework so that member states and donors can self-assess how they're doing in terms of progress in strengthening their research ecosystem. And this is not for you to look at. I hope that the slides will be shared, but just to say that over the next year or so, what we're going to need to do is agree a matrix where certain elements of the ecosystem are needed at the national, regional, global level, and we need to have ways of tracking progress. How do we prioritize at the global versus the national level? How do we improve quality? How do we improve the networking? I think we've seen networks, really have a big role. And again, many of them in terms of their collaboration are hosted with the Global Health Network, but we need to identify where we have gaps in the networks and how we can do better to develop quality protocols that can be rapidly implemented. And I think a big part of this is having different sections for normal times and emergencies. And what I would really advise that you do if you work in endemic diseases is, rather than see that the resources tend to flow during emergencies and we're all starved of resources in normal times, make the case, which is true, that the resources that go in normal times for the core capacities that are needed for endemic infectious diseases, for non-communicable diseases, those are the capacities that member states, countries will have that can be deployed during emergencies. That's what we saw. It wasn't actually the emerging infectious diseases networks that were most useful. They had the disease expertise. What delivered most of the research was what had been set up beforehand for HIV, for example, in South Africa, for malaria in other countries, for tuberculosis, for influenza. So let's have this narrative that we drive the capacity strengthening for what are the priorities in normal times, and that they need to have ways of being rapidly adapted to emergencies. This is the research and development cycle. You will have seen versions of this. This is what we have at WHO. And what I wanted to show you is that we have a number of sets of normative guidances that span enumeration of clinical trials with ICTRP, large-scale R&D visualizations with the R&D Observatory, and then a number of other areas in research priority setting that are available. They're for all of our WHO staff, but they're also relevant for those of you working on, for example, research priority setting in other areas. We also have a bottom-up focused approach called EVIPNet, which is bringing evidence as far as possible into policymaking. I'm sure you would all know that, unfortunately, sometimes policymaking isn't actually based on evidence. And we all have a responsibility to, as far as possible, bring evidence into policymaking. When we know our minister is going to be issuing a policy on something, if we have a week or 6 months to really systematically try and present the evidence, that's what this model is about. It's active in 50 countries, and in the slides, there are links to many, many resources for those of you who have an opportunity to try and convince your minister to bring in the evidence that you've generated in your country. This is a model for doing that. We also have a visualization of all of the grants that are made in global health through something called the World Report. And what that shows is, unfortunately, where we have international collaborations, it is still absolutely the norm that the primary awardee is a high-income country institution. And we have these subcontractor relationships with low and middle-income country institutions. We want to get beyond that at WHO. We need to figure out how to move past that. And so the federated model that we heard about from the Global Health Network, we need everybody to move to that. And I personally think this is a big problem if we still allow this situation with subcontractors as the norm for low and middle income countries. This should not be okay. The most neglected of all areas is something that you all should be aware of, which is that the global burden of disease now is actually focused on non-communicable diseases in low and middle income countries. But if you look at the very small proportion of the grants that go to low income country awardees, they're not for NCDs. Therefore, the narrative is infectious diseases, maternal and child health. So the ultimately most neglected area is NCDs in low and middle income countries. And we need to figure out how to convince donors that this is a major, major need. Diabetes, hypertension, cancer in low income settings. You all know that we have big gaps in research infrastructure, in research total amount coming out of developing countries, and our R&D Observatory allows you to look at every single country and see progress. And you'll see that there are some countries that have made major progress, like Ghana and Kenya, but some that we really need to help to catch up. Then finally, with the last couple of minutes, I've got, this is now not WHO, this is me, so I take the blame for this. In my 25 years, a couple of things that I just wanted to highlight. Firstly, the more that we have communities of researchers that have shared objectives and their work is based on what their communities, their local needs are, what the beneficiaries are asking for in the first place, the more the research is going to lead to impacts on the ground. And so some of the practical research that I saw yesterday is absolutely aligned with that. But I still think a lot of the time we have to make the case and plea that we have the time and the resources to do this consultation, because we're not doing the right research if we don't do this. A lot of the projects that get funded don't necessarily have sustainable research capacity development at their core as the core objective. The core objective is some other output like product development. But I really would advocate that we very much put sustainability, equitable access, and capacity development at the front of everything we're doing, and convince donors to, to support this as much as possible beyond the pure capacity development projects. Because I think in my career, when I look back, it's whatever I have done to contribute to sustainable research capacity development that I'll be much more proud of than any individual project. More initiatives are not always better, and I see many, many new initiatives being launched all the time, generally by some northern donor that has an idea, a billionaire philanthropist. And we need the money, and I really congratulate any donors that have supported this conference in this kind of cross-cutting bottom-up approach. But we should sometimes push back on a new initiative if we can actually do better by supporting what's already happening and focus on more collaboration and coordination of what's already happening. I have seen in my career a big increase in the bureaucracy and the burden on researchers that are trying to get work done. There is, if we piled up all of the guidance documents that you're expected to follow, if you literally just printed out ICH, then it would just fill this entire stage. And there are many other guidances that we're expected to follow. the quality of your research is not equal to the number of pages in the guidance document that you're expected to follow. So somehow I think that we need to have an explicit objective of reducing the burden on researchers going forward while maintaining quality. And this is in the resolution, which I think is a big positive of the resolution. It talks about identifying the key scientific and ethical elements that will drive quality and outcomes. And we need to figure out how to do that while reducing the burden. And then just finishing, you will see in your career, and I'm sure many of you have already seen this, that sometimes the current system is not working and something is just wrong. And a good example would be HIV medication, access to HIV antiretroviral treatment. When I started my career, and I'll stop within 10 seconds, my first job as a medical doctor was here in South Africa in KwaZulu-Natal in 1996, not long after the end of apartheid. And at that time, the norm, what everybody said was, we're not going to be able to provide access to HIV treatment in South Africa. I'm sorry that your people are dying, but the way the current model works, it's not going to be possible. And people fought that. It was activists that fought that. And now the norm is industry supports generic manufacturing and we have access. But remember, that was absolutely not accepted. So we have to sometimes go through these incremental changes to have the battles to get to where we need to be. And sometimes the activists need to come in. And then finally, have the courage of your convictions. There are going to be many points where people are going to tell you that you can't do what you think is important, but if you kind of stick with it, then you'll get there. Thanks very much.
Thank you very much, Varsi. I really liked the challenge at the end. And I know you said those are your personal nuggets of knowledge. So we won't hold WHO to that. So I'll encourage, we have 5 minutes for questions from the audience. I have a few of my questions, but do want to allow the audience some time to ask questions. I believe there are microphones somewhere. So yes, please go ahead. Yes. So there's microphone in the back. Is it just one? Any questions, please raise your hands. Yes, there's some questions up here.
Thank you very much for that enlightening talk. My name is Ola, I'm from Nigeria. I'd want to ask, when it comes to driving collaboration, when you have a lot of resistance with the institution where you work, what do you think works for someone who you are an early career researcher? What do you think you should do when you want to drive collaboration?
Yeah, I wasn't sure if it was collaboration at what level, across institutions, within your institution, across institutions. I think the important point that I have seen works is where you will find people who have shared objectives with you. And the more you can identify a community of researchers or people, it doesn't have to be pure researchers, health workers, nurses, and they have the shared objective. The shared objective could be something really practical and simple. In different parts, in different countries, people have stopped coming for antenatal clinic attendance. And we know this is a big problem. But as long as you can start with a shared objective, then whatever your differences might be with the framework that you're in, I think it's really possible to overcome that. So that would be my, my tip. Focus on the shared objectives and then figure out how you can work together. But that you will always, it will take a while, and sometimes it seems frustrating. It might take you, but that effort that you put in at the beginning of setting up a community with shared objectives will mean that the impact later on is going to be so much greater, in my experience.
So I think we'll take 2 questions back to back, if that's okay with you. Okay.
Thank you very much. My name is Eleanor Magongo. I'm a pediatrician from Uganda. I work with the Ministry of Health. I wanted to ask, why is the role for routinely collected data in using this to inform what we do in our different countries? Can routine data have a place or a role in the policy setting, because a lot of data is collected almost weekly, monthly, quarterly. How can that play a role in what we are doing? And the other one is a comment. If we have a lot of funding, for instance, in the HIV programs, can we integrate what we are doing? Can we integrate NCDs, the same patients we see with HIV, have hypertension, diabetes? Is there a role for integrating and leveraging on the funds that are available in some of the programs? Thank you.
Okay, thank you so much. My name is Oyewole Edele from Nigeria. I just want to, it's a follow-up question for my brother here regarding data interoperability. Recently, we engaged on a project on COVID-19 where we have to operate a different reporting platform. So during these activities, we engage in some, just like you said, stumbling blocks. The organizations are not interested in sharing data. And despite the fact that we have common objectives, as you have advised, it's quite challenging for us. So I just want to know, what other strategy do you think we should adopt in order to, strengthen or foster collaboration? Thank you so much.
Yes. Sure. Okay. So I think we're going to have a whole session on data later. But I think these are really important questions, and thank you for the questions. My personal take is that in terms of sharing of the validity of routine public health data, it's vast. It's just absolutely vast. It's largely untapped. And I think a very important framing here is that a lot of the global initiatives that I hear about are requesting that you provide your data to them. And I think that really the important gap that I see is a major focus on supporting the capacity of routine national health information systems. And the countries that really have been able to go furthest with applying their routine public health data are those with sound national health information systems, like in the UK, where they have actually been able to do very, very large scale analyses for secondary purposes. So the key issue is, how do we have this narrative of supporting the national health information systems, rather than the narrative being, please give me your data so I can do an analysis in Europe or North America. Again, that's my personal opinion, but I really think it's very, very important that we figure out how to support the quality of national health information systems. And we'd absolutely need to have standards and curation efforts and interoperability. And from that, we can go. And I think another important point is that we shouldn't, the only way that we're going to get trust in, because there are a lot of concerns that I know that some ministries have about privacy, etc., electronic health records. The best way to ensure trust is to build trustworthiness in the way that we do this. So there are other models that are being used now, for example, with federated data analyses. There's something called trusted research environments. I think UKHDR are here. And they don't require you to export your data. They allow you to deploy code on the server without exporting the data and run analyses at very large scale. And I think when we don't necessarily have to always export our data, but we can run global analyses, that has a lot of additional possibilities. But in some cases, clearly we will need to aggregate the data, but then we have to focus on the quality and be very, very sure about the safeguards, because I have seen real examples where there have been leaks, and let's have trustworthiness. In terms of what you said, I think what you said about integrating between different areas, sorry, I'll stop, is actually probably the short-term way to go for NCDs, because what we see in developing countries is that there are HIV programs, TB programs, malaria programs, there's flu labs. they all have major comorbidity links with NCDs. And so if people are coming for HIV appointments, you can collect data related to hypertension, for example. And I think that probably is a really good short-term way to go to answer some of the NCD questions. Okay, thank you.
Thank you again, Varsi. We will move right into our 4 talks for the morning. So we'll have our presenters go one after the other. So hold your questions till the end. You can still include questions for Varsi as well. Our first presenter is Dr. Anani, and Dr. Anani is with Program Paki in Côte d'Ivoire, and he'll speak to us about building a research network through clinical research collaboration. Right after that, he'll be followed by Dr. Jose, who is with the Social Innovation in Health Initiative in the Philippines. And he will speak to us on the coordination of a global network for creating enabling environments for social innovations in health. Followed, right after that, will be Dr. Glenda, who is with Hospital Británico in Argentina. And she'll talk about the presence of the scientific committee coordinator and how that contributes to enhance the academic development of the hospital. And then lastly, we'll hear from Dr. Fernando, who will then take us into beyond theory and looking at methodological mentoring to strengthen health research. So again, all of these topics relate to how we build and foster leadership and capable research teams. So I'll start with Dr. Anani, please.
Thank you very much. Good morning, everyone. Can you hear me? Okay, it's my pleasure and an honor to open this session of presentation by presenting the FISA study as a builder of a research network. I have 9 minutes to present what we did in 5 years. Let's go. Sub-Saharan Africa is prone to frequent epidemics, which needs a coordinated and appropriate response. One of the pillars of an appropriate response is a robust and effective research network. There are hardly any research network in Sub-Saharan Africa focused on epidemic response and research. The African Coalition for Epidemic Research Response and Training, ALERT, was put in place to help filling this gap. This slide shows the governance of the ALERT consortium. You have the executive committee that report to the General Assembly, and under this executive committee, you have all the work packages involved. We have 7 work packages coordinated by the work package 7. We have the work package 1 in charge of research, 2 lab, work package 3 IT, work package 4 operational readiness, work package 5 led by Trudy and Palmer, training, work package 6 community engagement. ALERT is 19 partners in 13 countries, 4 in Europe and 9 in Africa. As part of ALERT network, as part of this consortium, we implemented the FISA study. FISA stands for Fever in Sub-Saharan Africa, as simple. And the objectives of the FISA study was to describe the epidemiology, clinical aspect, and management of febrile illnesses in Sub-Saharan Africa. This is the scientific objective, and we have also the strategic one that was to build a clinical research network capable to respond rapidly to epidemics, and we will emphasize on this objective. How this study was organized, you remind this diagram is the same, but here we have the work package 1, that coordinate the FISA study. This work package 1 is led by Professor Pontiano here, and all the work packages are involved. You can see that here, the work package 7 is not the coordinator, but was in charge of management of the fund. This other diagram shows the relationship, yes, between entities. We have the ICMC, the International Coordination and Monitoring Center, led by the work package 1 with 3 regional coordination with site, clinical site, and in clinical site, we had supervisor and PI. The supervisor was designated by the partners, the allied partners that proposed the site, and the PI was part of the local team. This organization contributed to build the network. The process of the setup was the following. We drafted a site selection procedure, and all partners that wish to propose a site did it. So we have 26 sites proposed by 16 partners. We validated the list by the steering committee, endorsed by the executive committee, and at the end, 15 sites enrolled participants in 11 countries. 6 countries in West Africa with 8 sites, 2 countries in Central Africa with 4 sites, and 3 countries in East Africa with 3 sites. I would like to greet Bernard, the coordinator of East Africa region. The key point of the implementation, drafting the protocol and development tool, approval of ethics committee, training. The first inclusion was in December 2019, and we ended the recruitment in December 2021. All these supported by meetings and monitoring visit, monthly steering committee meetings, monthly international coordination meeting, bi-monthly regional meetings. All these meetings and visits contributed also to build the network and strengthen it. We faced some challenges. Few challenges to summarize: the management of several ethics committees with different procedures. It was a challenge, and we faced a big challenge with one country, and we were obliged to work around with submission to a regional ethics committee, valid, because the National Ethics Committee was it was very difficult to move forward with this ethics committee. The COVID-19 pandemic that I call the great unexpected, with the reduction in inclusion and site visit impossible due to the restriction. This was also a challenge. Turnover in trained staff. We have several staff trained, but some of them left. And the communication difficulties due to language barrier, because the network is a bilingual one, English and French. Fortunately, we have achievement. Introduction to research with development of interest in research in some teams, because we have several kinds of teams, beginners and also well experienced. But the beginners were very happy to be involved in this study, and today they are ready to welcome a new study. The management in a bilingual way. All emails, reports, documents were translated, and we manage things like this. Remote monitoring of the study to respond to an unexpected restriction. So due to restriction, we were obliged to make things remotely. Survey on laboratory capacity in collaboration with Work Package 2, and development of e-learning module on the protocol in collaboration with Work Package 5. This was some example of collaboration within the network. And establishment of a research network through linking of researchers from different fields, different languages, in different regions, with different practices. This is very important. We managed to build this network with all these people. And today, beyond the work collaboration, some of them are very good friends. And within the network, we already developed other collaboration on new project, and we are still working on this. To conclude, I can say that FISA study succeeded in creating a network of research sites that have grown stronger over the years. Several lessons learned from the implementation of this study will be used to strengthen and expand this network. It is a model of research partnerships for an equitable response to health emergency. So this network is built and ready for new research on epidemic-prone disease. It's a message to all funders here because the outlet will end next year. So we are ready and we are there. Okay, thank you. 5 seconds left. I did it. Thank you very much.
This is on. Okay. Good morning, everyone. I am Dr. Serena Bagani Cruz. I am part of the Social Innovation in Health Initiative Network Global Secretariat, and I will be presenting about our work in coordinating a global network for creating and enabling environments for social innovations in health. So our network, Social Innovation in Health Initiative, or as we like to call it, CHI, so the C high. It was initiated and is still being supported by the TDR, and we receive funding from the Swedish International Development Cooperation Agency, or SIDA, along with our many partners. So to level off, we at the network define social innovation in health as a solution, which can be a process, product, practice, or market mechanism that is implemented through diverse organization models. The solutions have been developed by a range of actors or stakeholders, ideally including the communities where these innovations are implemented. And these solutions are in response to systemic health challenges within the context of the communities. It profoundly challenges the current system status quo and has enabled healthcare to become more inclusive, effective, and affordable. So a brief overview of the network's history. So the CI network was established in 2014. It started with a innovation call, a global innovation call. The very first hub was established here in the University of Cape Town. Over the years, after the global call, we had country level calls for innovation, and then establishment of hubs. Currently, the network is still expanding. Currently, we have 13 hubs all over the world. So what is a CI hub? A hub is a research institution-based social innovation health hub. Usually these are university-based hubs that bring together various stakeholders such as the innovators, the community, academe, the government, private sector, and health implementers. The hubs do research on social innovations in health, also capacitize the various stakeholders for research. They advocate for social innovation in health and convene the various stakeholders with the aim to institutionalize the innovations in their health systems. So overview of the network. I won't go through each organization, but just to show you the extent of the network. Currently, we have 13 hubs. I think it's a bit hard to read, but on your left, we have the very first hub here in University of Cape Town, CI South Africa. And we've eventually expanded to 6 hubs and then 13 hubs currently. We have hubs in Philippines, China, India, Indonesia, Uganda, Malawi, Rwanda, Ghana, Nigeria, Honduras, and Latin America and the Caribbean, and Sweden. So with this expanding network of hubs and partners, the network saw a need to have a coordinating body to coordinate the activities and the hubs. So in April 2020, which was just in time for COVID, the CHI Secretariat was established within the CI Philippines. So part of the work of the Secretariat is to coordinate the hubs. We do this through monthly meetings, which provide the hubs platform to promote their activities, to share experiences, best practices, and their work, basically, to other hubs. We also meet with various partners of the network, and also with potential partners to explore potential collaborations and partnerships for social innovation in health. The CHI Secretariat has also coordinated joint research grants, applications, and implementation. We have also assisted in publishing a special issue on social innovation in health in the BMJ Innovation Journal. Aside from that, the Secretariat also provides technical support in terms of communication to the hubs through promotional materials. We help the hubs to create promotional materials for their innovation calls, and also assist them with the branding of CHI. We also manage the website, the email, online conference platforms such as Zoom for the meetings, and the social media accounts. We also help in sustainability of the hubs by seeking grant opportunities and funding for their activities. So just a brief overview of additional achievements of the hubs. We have fellowship programs, a crowdsourcing guide for research, and other various courses. So I would have loved to share with you pictures of face-to-face, but unfortunately, because of COVID, we had to be restricted in online settings. So on the top right, you would see one of our promotional materials. We try to make it as engaging and fun to capture our participants' interest. And at the bottom, you have an example of our group pics in Zoom, where we try to make the most of it, given the technology. And although recently we've already started face-to-face meetings, as with the rest of the world. So on the top left, we have our lead of the Secretariat, Dr. Meredith Labarda, at TDR headquarters. So with that, thank you for listening. Yeah.
Hello, my name is Glenda Ernst, and in the first place, I would like to thank the host committee and especially Dr. Rumi for inviting me and give me the possibility to share with you what we do on the daily basis. I am molecular biology and work like basic research, and then I have clinical research, but currently I am a coordinator of scientific advisor committee, and I am enjoy extremely much. Worked as train of resident to enhance the research capacities. Our work is entitled Presence of Scientific Advisory Committee and its contribution to enhance the academic development of the hospital. I work in the British Hospital. Our hospital is a teaching hospital with more than 175 years in the training of health personnel through learning in healthcare practice and encouraging participation in research work. Why it's so important for us that health professionals learn to do research work? Because we are convinced that research could contribute to understanding how to improve the care we provide to patients. The Scientific Advisor Committee was created at 2016 with the aim of contributing to training of healthcare professionals in development of scientific research through implementation of continuous training strategies to improve the quality of care. We have a room and a coordinator that is in charge, who is in charge of meeting in person with research group and PhD students in order to provide methodological and statistical advice. And the rest of members are regularly weekly meetings to evaluate the new submitted protocols. There is a unified assessment guide to evaluation of each new project, and we evaluate different topics, and we put a special attention in PACO rule, especially with definition of the outcome, calculation of sample size, and rationale for their action. We invite our residents to think if thus the studies could be increased the knowledge or changes clinical behavior before to start. And give different feasibility for the researcher, like a step-by-step guide to writing a research project, step-by-step to opening user account in Buenos Aires, works a rate of computerized registration of all research projects called PRISA. And we follow the researchers during the complete performance of the project. We provide support since brainstorming, writing the protocols, we provide support with management of clinical sample, statistical analysis, and finally, we help to select the journal and publish the result. And have different annual training activities. The most important training activity is transversal course on research methodology. It is mandatory for the third year's resident and fellow. We each year have between 16 and 18 pupils, and it's important because some residents end with presentation of a research work. And each year we define different topic for interactive workshop. At 2022, we worked in systematic review and meta-analysis and statistics with RStudio. And by the next year, we try to develop interactive workshop in randomized experimental studies and statistics with RMedic, because we think that maybe is more easier for our residents. We encourage them to increase the number of publications. When we was created, the resident presented our abstracts in different meetings, but never they published their results. So we encourage them to share the information in different journals to build in breadth and share our information. If good, our hospital is academic and always publish Since we are created, the number of papers are growing. And on the other hand, is a priority for us to train leaders. So we want to work in develop durable lines of works. The number, since we are created, the number of PhD students and the numbers of the health department are growing. So I think that is important because the enthusiasts are growing noticeably. Since we the committee was created, we had 400 protocols, more or less, with different lines of works. We have several lines in epidemiological studies, but on the other hand, we have several implementation studies with giving capacitation and measuring different outcome pre-post implementation. And we have an agreement with Catholic University and give me the possibility to develop different translational research, measuring different biomarkers or molecular markers. And we started to develop in different chronobiological lines of studies. Okay, in accordance with the Global Health Network, is our main objective to train personnel to improve each step for development research studies as daily tools. We encourage different residents that see that work age by day could be improved if we use the research works as a daily tools. And the key to leading research team is to be humble, a simple person, and with great generosity motivate the growth of other professionals, sharing all our knowledge and support. We try that the leader must be an ambitious plan, but should be facilitate every step in the professional improvement for their peers. And to put in this, I am coordinator of the Great Scientific Advisor Committee, and they are the members. And we have different PhD students. They are my PhD student. I have 2 nurses, pharmacists, residents in traumatology. So I am so happy to see this growing.
Hello, everyone. Good morning. And first of all, to thank the Global Health Network for this great opportunity to be able to present part of our experience in the Institute of Clinical Effectiveness in Argentina and be part of this newest member of the family of the Global Health Network Latin American Caribbean Network. I'm going to present just a pilot experience that we've started about mid-2018 and show you the first results and some ideas to reflect on that. So the mission of the Institute of Clinical Effectiveness is, as we all are seeking, is contribute to improve global health. And, And the main activities that we develop at EX is education, research, and technical cooperation with other institutions or other groups. Argentina is the southernmost country in America, as you probably all know, and we're always facing a chronic, challenging economic situation, which never seems to improve. But despite all the efforts, actually research does not have a prominent role in training. And training is more geared to practice, to professional practice, and research abilities is usually not included in the programs. And we have almost no economic incentives or funding agencies to support locally our own research. So at IEX, the Department of Education set up this pilot project, which we call the Bridge Mentorship Project, which promoting and strengthening the training of health personnel, health professionals, to generate and lead local and regional research. And a great challenge, usually, for all educational and scientific communities. So this program, this pilot program, was set up in mid-2018, as I said, and we shared, because of the pandemic, we started doing our work at face-to-face consulting, and then moved to completely virtual by Zoom or any other platform, consulting with users. We were 3 mentors, 2 physicians and 1 nurse, solid training in practical experience, in research methods, in biostatistics, in good research practice, and research ethics. We set up a clinic, a methodology clinic, actually having appointments, offering about between 8 to 12 hours a week of 1-hour slots for for users who were willing to consult the team on any aspect or any phase of their own project, be it from the first or from the research question towards a manuscript preparation and help for publishing. It was partially funded by our own institution and the collaboration of the institutions of the users, but at no cost for the users themselves. So some of the results over those 3.5 years, we've had about over 1,500 consultations. And as you can see in the graph, it shows the pandemic entering in 2020. So we moved completely from face-to-face meetings to virtual meetings. Those 1,500 consults were actually done by 419 users, different users, and mainly there were half of them were physicians, 35% of them were nurses, and other health professionals were 15% of the users. The main reasons for consultation were preparing manuscripts, design of research protocols from the research question to designing the protocol, or conducting the study and statistical analysis of the results. Satisfaction of those completing the survey, 386, was very high. We were very happy with that, of course. And the mentees' achievements in this 3-year and a little bit over 3-year project were about several projects awarded, actually grant writing, whether local or international. Some papers, several papers published in peer-reviewed journals, many presentations in scientific meetings, over 60 presentations, scientific meetings, and we've had 8 master's and doctoral research theses. There's a great latent need for capacity building. We all know that. Methodological support goes beyond the theory. That's why the title of this presentation. Going beyond theory is really important. Training is important, essential, necessary, but not sufficient to really change the game. We need to go along after training, supporting the research, the development of the research projects, from the first idea to completing that, to manuscript preparation, to helping to publish, and then to go and advocacy. We move from practice, from research to practice, to use the best evidence. Then we move back to research to generate new knowledge. And then it's after generating new knowledge, we need to go further from research to policy. And that's the way we are going to be able to change the story. The acknowledgement go to all the mentees first, the health institutions and medical societies that participated in this program, the Global Health Network, for allowing dissemination of this pilot first project, and a toast for our joining the GHN Latin American and Caribbean Network. Thank you.
A big thank you to all of our presenters. I think the hardest task for any chair of a panel is trying to summarize what we've heard. I will not attempt to do that. I'll just highlight a few things as I encourage your questions. We have about 15 minutes for questions. So I thank the last speakers for saving us some time. But in general, we've heard from our speakers on just some really good lessons in creating partnerships to enhance the research we're doing. And then from our last speakers, I think those were very great examples on how we can actually build research capacity. And it includes a lot of hand-holding. I think sometimes we say, write a research grant. And for some people, they don't even know where to start. And then once you write the grant, how do you design? How do you think about it? Going through the ideation process, and then moving from now you have the grant, you've written, you have your outcomes, then what do you do? So I think those are really fantastic examples on how do we handhold, how do we mentor as we try our best to grow research capacity and grow leadership in research. So with that, that's my attempt at summarizing the last 30 to 40 minutes. And with that, please do raise your hand if you have any questions for our speakers. The microphones will come around. There's a question right here and two here. And I think let's start here and then go there, because this middle row had a lot of questions in the first session.
Yeah, thank you to all the presenters. I'm Sam Muhula from Kenya. My question is to Dr. Anani. You did mention that one of the challenges you experienced was getting ethical approval in one of the countries where you are implementing the study. And so you were to abandon the country-specific IRB and go to regional one. And in my experience, yes, it's a challenge to where you are doing a study in multiple countries. And so I wanted to know which is this regional IRB that you are talking of, and whether it is okay to bypass a national IRB and go with regional. How did you face further challenges collecting data in the country? Because those are some of the things that we've gone through. Yeah, thanks.
Hello.
Hello? Okay. I'm sorry. I just wanted to understand very well the question. So you wanted to know what was the... Yes, Palmer? Yes, you wanted to know what,
Go ahead.
Donc, en fait, il voulait savoir ce qu'on a fait à propos de contournement qu'on a fait avec
Yeah.
le comité d'éthique national pour aller vers le régional. Je crois que son entendement par régional, c'est que c'est sous-région comme Afrique centrale. Or, c'est pas ça le cas. Dans notre cas spécifique.
Yes, this ethics committee was also valid, right? Okay, it was also valid, like the National Ethics Committee. So we face big challenges with the National Ethics Committee. So on advice of someone in the country, we go towards the Regional Ethics Committee. Because if we waited again, this can lead to delay in the implementation of the study. So this was the big challenge, because most of the time when we have multi-site, multi-country studies, we want to start at the same time, but due to ethics committee challenges, sometimes we have some delay. So I don't know if I reply to your question.
Yeah,
I hope.
Thank you, Anani. So we'll take 2 more questions from this section, and then we move over to that section, please.
My name is Mahesh Maske. I come from Nepal and represent Nepal Public Health Foundation. Actually, my question is directed to Dr. Murthy, because listening to all the speakers, then I thought I should direct my question to you, Dr. Murthy, because everybody is emphasizing on equity issues. And you also said that while strengthening the capacity, research capacity, we should pay attention to sustainability and equitable access. So you have a long service in WHO. I'm quite interested to know what has been the top success stories of WHO in reducing equity gaps. Or, if you don't have many, you can share your frustration stories also. That's fine.
That is a tough question. So his question is, because in your talk you mentioned the importance of sustainability as one of the key areas that we should think about. And so he's asking, equity gap, And so the question is, considering as well your tenure at WHO, and so what are those, like, in a practical sense, how do we then close those equity gaps? And I'm paraphrasing and probably adding my own in there. How do we close those equity gaps and also think about sustainability as we do so?
Well, if you work out the answer, please let us know. No, I mean, but to be honest, I think this is the $64,000 question in global health. What we have seen is that there have been some examples of success. So I hope I wasn't too downbeat, but I think there have been some examples of success. One of them, but they have been sort of patchy, and some countries have been maybe more successful. I mean, to give you, just to highlight at the very highest level, in terms of equity, we do have one globally agreed framework called the Pandemic Influenza Preparedness Framework. Now, the pandemic that we just had was not an influenza pandemic, but if it had been an influenza pandemic, then there were equity clauses that all governments had signed up to and all industry partners had signed up to ahead of time. So which would have guaranteed that 10% of the vaccines would have been made available in real time. Now, I don't know if you heard about COVAX, which was the COVID-19, and because we didn't have any agreements in place ahead of time, we didn't get anywhere close to 10% in the last pandemic. We got to about 3% of the vaccines that were actually made available according to need. But in reality, the people with the most money went to the front of the queue, and they had, multiple contracts in place. There were many countries that had 5 vaccines secured for every one person, and then there were many countries that had almost no vaccine. So I think one big lesson is that, we have this idea of like an overnight success story. Doesn't exist in my experience. Every time there's an overnight success, it's actually a 10-year story. And so the PIP framework took about 5 years of negotiation, kind of boring negotiation between teams. But that work means that now, if there's an influenza pandemic, we do have an equitable framework. In terms of equity, there's also the Nagoya Protocol, which is not in the health sector, but there are these principles in the Nagoya Protocol which are actually fully aligned with what we think about in terms of equity in health, fairness, equitable access to the benefits arising from resources. So there are some pointers. And then now there is the pandemic treaty, which is or accord. I think the final title is not yet agreed, but there is a formal intergovernmental negotiating process that is underway at the moment between all of the countries of the world, including there will be elements on research, equity in research in that framework. So we'll have to see what comes out of it. But then just to finish, the other part is, I think, where we have made the case, and I think some countries have understood that your research capacity is a central enabler for your people, okay? If you do not have research capacity, including in health, you are not going to be able to answer questions to help the people in your country. So in some countries, the political level have understood that it is in the interests of people research shouldn't be seen as some kind of ivory tower discipline. It needs to be seen as providing practical solutions for your people. And if we can get that message across to the politicians, then I think the resources will come. And in some countries, we're starting to see that.
Thank you. So one more question from here, and then we'll move to that side of the room.
Okay, thank you. My name is Mateus Sani. I'm a medical doctor and global health specialist. I'm based in London, working with the London School of Hygiene and Tropical Medicine. So my question is for Dr. Vasi from WHO. So you said that to make the results sustainable, we have to do research based on the community need. So I want to know how this can be a reality, because most of the time people apply according to the requirement of funders.
So I think the question, let me attempt to paraphrase, is so you were asking in relation to basically funding research, and you're saying most of the times people apply. If you could just repeat.
So people have to comply to the funders' requirements, not necessarily the community need. So how can we make the research being based on the community need, make it a reality?
Oh, I see. So basically okay. So the requirements basically align to the funders' expectations. But if we're talking about engaging communities, how do we ensure that those requirements actually take into account sort of the input from the community?
Well, that's a great question, and I don't have a perfect answer. I think all we can do is make the case to the funders that, and I think some of the funders, already do take this on board, but we should not hesitate, in my view, we need the funds. So don't get me wrong, nothing will happen without funds, but at the same time, we need to have hopefully a two-way dialogue with the funders about the importance of engagement with communities. And I think it should be possible to explain that the benefit and the outcome, the funders are looking for impact from their work. So if we can explain that we can improve the impact by really having a budget line and time to engage with the communities and really understand how the research is most likely to benefit the communities, then it will be in the funders' interest as well.
So we'll move to this side of the room and no more hard questions for Varsi. Those are no longer allowed.
Thank you for this opportunity. I'm Farah Asif from Lahore, Pakistan. And my first question is for related to Alert Network. So you mentioned that in your region, many networks were not existing, they were lacking. And then you went on, you were determined, and then you developed this network and had your desired results as well. So what were the challenges you faced? Because how you made that change happen? Initially, the networks were not there, but you go on to this, to take on this challenge, and then you develop this network. So because we believe that we can learn from this experience, because when you say this, that networks never existed, it sounds very familiar to me, to the context of Pakistan. So I would like to hear from you, because what were the challenges, and then how you just overcome those challenges? That would be great to know. And if I'm allowed, I have a second question. Can I ask now?
Let's take just one question so we can give others a chance.
Okay, that's great. Thank you. Thank you.
And I'm assuming your question is, you didn't say who was directed to? To Anani. Oh, sorry, I missed that. Yes. So the question, I'll paraphrase your question, is around basically the challenges. So the challenges in building the research network that Anani spoke about, and maybe just highlighting some clear challenges in building this network and how they overcame those challenges. Is that correct?
In the region, the networks were not there. The networks were just lacking. And then they went on to develop this.
Yes.
So how they made that change happen? Thank you.
Yes. So Anani, it's from creating this network basically from nothing. The challenge of creating that network, of building that network, and how you address those challenges as you build the network from nothing, basically.
Okay, I think at the beginning of the consortium, we had people, we had work packages, but we did not know each other. So we needed to create the bridge, to create the links between people. And when we implemented the FISA study, we had several documents, because it was very important for us to create communication. So several documents, several procedure that help us make people working together in the same way. I also talk about the meeting we had. We have a lot of meetings to discuss between researchers. And as I was saying yesterday, I used a lot WhatsApp. I have the WhatsApp number of all, at least one people in each country, in each work package. And I did not hesitate to send message to create this link. So as I said today, beyond the work, we are for some friends, and we work together for further challenges, further collaboration. So we try to create this network, but the FISA study was central. All the work packages worked around the FISA study. For example, the database was built by the work package 3. I take opportunity to greet Bai, the lead of this work package, the training work pack, all the work packages were involved in the study, you see, and we created this network through the FISA study, through the study. I
So-
hope I understood. Okay.
So apparently, we do have to, that would be our last question because we are the ones between you and the coffee break. And so we've been getting all these signs saying to stop. Could I ask Trudy just a last round from each of our presenters? Very short, thank you. So just to close our panel, and first of all, thank you very much. And I apologize that we didn't get to all of your questions, but maybe just a last lightning rod from our presenters as we close. Just one question, and I'll start with you, Fernando. And the question is the same for all of you, and it is, what is the most critical thing when we talk about building leadership and capacity in research? That's it. Very simple, just one thing.
Yes, very simple question. Yeah. Actually, many things probably to work for leadership in research, but as I said before, training is important, not sufficient. Mentorship is important, and we need to go along after training and after formal training or informal training to develop research ideas. And we need to create networks. We need to collaborate. We need to reach out for help, give help, and reach out for help when we need it. And I think that the formula of creating networks and having developed different areas of research and strengthening those areas by the collaboration of many people around that network is a key.
Thank you. Glenda?
I am in agree with my colleagues, and I think that is very important to think that is we need PhD leaders to motivate and grow and help the new research. When our residents start to work as researchers, they have very much enthusiasm, but sometimes we need to do more behind, because we need develop long and lasting leaders to train the resident, and we need to think that is possible, that the residents finish their resident studies and PhD in the same time, and they work much good with us to finish both of them together.
Thank you. Jose?
It's working. Okay. I think it's more of having an environment that would allow the prospective researchers to grow, having mentors to guide them, but having the room to allow them to make mistakes, because you can learn as much from a book, but there's really nothing to replace experience. So I think that's it.
What I can add to what is already said is that I think we have to involve people earlier when they are during their study. For example, for medical study, I think research should be teach very deeply at this time, not wait when they finished the study and they are on the field before try to catch up.
Yeah.
I think nurse, medical student should be trained very deeply when during the study. I think this is something important, and we will see the fruit after.
Thank you.
For me, I won't add just to say something different to the others. I think instilling the culture of leadership in your training program is absolutely central. When I see the places that a lot of the leaders have actually come from, there are some places where there is this norm that we are going to create leaders. And I think that's really central. And then being part of a peer network of leaders. But also the other thing that I think is really central is representation of these leaders, of you all, the ones that are the leaders. You need to be at the decision-making table of all of these initiatives, rather than just being people who are applying. We still are in a situation where the decision-making structures do not actually represent what we're trying to do. So until we move that, I think we're not going to get to where we need to be.
And with that, I thank all of you for all of your contributions. Thank you so much. I'll hand it back to Trudy. I think these were really fantastic conversations. We also have an opportunity to continue these conversations. AMREF Health Africa is hosting a similar conference, and we'll be picking up on some of these themes. That conference will be in Kigali in March, and it's the Africa Health Agenda International Conference. So please do join us, and that way we can continue these conversations as we really talk about leadership and capacity building. Thank you so much, and thank you, Trudy.
Thank you so much. That was such a brilliant opening session. I really appreciate that. So now we have a bit of exercise, because we're all about non-communicable diseases and staying healthy. So you have to jog to your coffee and whatever else you need to do, and come straight back and be sat here ready for the brilliant next session we have to start at 11. So ready, go.
Hello. Good morning, everyone. Sorry, just before you escape, could we just kindly ask if Amina Nalwoga is in the auditorium? Amina, if you're here, could you just make yourself known to the team over here on the right-hand side, please? And any session 2 speakers, could you also report over here on the right-hand side? Thank you.
I'll let you know.
Hello, everybody. Welcome back. If you could please take your seats and we'll start this session. I have the very important task of getting you to lunch on time, and then we've got some things to do before that. So we better start promptly. So in this session, we're going to be talking about ensuring that research findings are taken up into policy and practice. And, you know, just speaking personally, I found two things really important in this aspect. The first seems very basic, but is really important. If you want somebody to listen to your answer, then answer their question, not your question. Make sure you're answering the question asked by the implementers, not the question that is of most interest to you as an investigator and a researcher. And this takes it to the next stage, because those best placed to ask those questions are the people who are implementers within the health systems. And we'll go one stage further than that and say that often the best people to research those questions are those very people who are asking them in this way. I think we really need to realize that research is a spectrum, and it's great. And some of us have got a background in academic research and we go for that, but it also needs to be a tool in the hand of implementers. We need to democratize the research. We need to make sure it's available and usable for everybody. The second really important thing is a really simple phrase, is that what is important is not what you are saying as a researcher, but what the policymaker is hearing from you. And so communication is the second key to this. So making sure that we're able to communicate what we are doing really clearly. And I hope some of you came to the AMR symposium yesterday, where we were showcasing TDR's structured operational research training. And as part of that, we now train people not just to do the research, but actually to develop policy pitches, all the way from meeting a minister in an elevator to bumping into somebody at a conference. And I've got some breaking news right now. Just an hour ago on my phone, for the first time ever, we've got a journal, and this was the MDPI journals that publish tropical medicine and infectious disease. Underneath the abstract are going to publish a flash presentation by the investigator explaining the policy relevance of their research, so the story can be taken across. And literally, I haven't got this, but Ronnie Zachariah, Ronnie, do you want to just give a wave there? Is the lead on SORTIT for TDR. So if you're interested in following up on that, please catch Ronnie a little bit later, but really exciting news and really important. So answer the right question, make sure you're framing that answer in a way that can be taken up. And let's hope we're going to see some of these examples as we work through our panel today, some fascinating talks to be discussed. So I'll move very quickly and introduce the plenary speaker. And the plenary is Dr. Alia Nahid. Alia is a health systems specialist at ICDDRB, and also she is the lead for the Global Health Network and the Asia Regional Coordination Center. So thanks, Alia. I'm looking forward to hearing what you've got to say.
Thank you, John. That was a kind introduction. And what a pleasant morning and excellent opportunity to speak in a plenary of the first The Global Health Network conference. Congratulations. So I'll try to give this experience that we walked through in Bangladesh and also with other countries in building research into health systems. I'm not going to present in research, but I'll try to give some essence what we learned from it. At a glance, Bangladesh, probably most of you know where it is. It is a small country neighbored by India, Myanmar, Nepal. And it is a small country, but more than 165 million people live here. And density is pretty high, and 1/3 people live in urban areas. But the health expenditure for people is so low as 2.48 GDP per capita, and it is only $46. More than 73% of health expenditure is borne out of pocket. This is quite substantial. But there's some good news. Bangladesh has achieved Millennium Development Goal ahead of time by reducing the child mortality and maternal mortality. More good news continues. It has excellent economic transition, and the per capita GDP is now more than 1,500. That surpasses many other neighboring countries. In the past 16 years, life expectancy has substantially increased for both male and female. And as of 2020, life expectancy is 73 years. quite impressive. But there are backsides. Along with this economic and other transitions, the country has tremendous epidemiologic transition of diseases. If you look at this bar, the blue bar represent infectious diseases deaths in Matlab Health and Demographic Surveillance located in Bangladesh, which is the longest health and demographic surveillance in a lower developing country. And the red bar shows the margins of non-communicable disease deaths in the population. So the blue bar is narrowing over time and the red bar is emerging and it is expanding further. Indeed, non-communicable disease is attributing to 71% total deaths in Bangladesh. And the sad news is 46% of these deaths occur in younger people, 30 to 70 years of age, which is we mark as premature deaths. The trend that is projected for Bangladesh is probably not going to meet the goal of reducing premature deaths of 25% by 2025. This is concerning. And more concerning that stroke and ischemic heart disease, those are the two top killers that constitute cardiovascular diseases. That is 1/3 portion of the NCD deaths. But the good news is, it is hypertension or raised blood pressure that actually attribute to cardiovascular disease risk factors. And evidence suggests very strongly that just 2 millimeters of mercury reduction of the systolic blood pressure can reduce 7 to 10% of risk of heart disease, stroke, and other related deaths. How amazing. And the hypertension burden is emerging. Every 1 out of 4 adults have hypertension. 60% of them do not have their pressure under control. And 1 out of 3 individuals or more than 40 years have chronic kidney disease developed, most of them accompanied by heart and stroke episodes. And these estimates are higher than other countries in South Asia. The problem is, this is a health systems approach and we need health workforce to provide services to huge community, but there's a scarcity of healthcare resources. We have more doctors than nurses and paramedics, and we have more private hospitals than the government hospitals. And they're mushrooming of private hospitals, although they're expensive, people go there because of their convenience. So the situation doesn't look good for hypertension control at the moment. But what we did, we came up with a multi-component strategy for hypertension control in South Asia, and 3 countries implemented a strategy called COBRA PPS. COBRA is not a snake. It is control of blood pressure and risk attenuation in 3 countries. The multi-component actually was driven by grassroots level health workers who were trained how to measure blood pressure and how to educate population with hypertension and their families to reduce the risk of NCD, such as promoting healthy diet, increasing physical activity, reducing smoking and salt intake, and reducing stress and alcohol intake. These health workers, when they measure blood pressure, if somebody had problems, they referred to a nearby facility, which was a part of the intervention, and they documented it. And in the facilities, there were doctors who were trained how to treat hypertension following an algorithm-based case management guideline that did not exist in the country at that time, and also treat associated comorbidities. And there was a triage coordinator who is the chief of that facility who actually coordinated, monitored, and supervised the doctors' work and the health workers' work in the community. Only problem was that there are many poor patients and some facilities were further from the community. So for the poor patients, the component of financial compensation is included. But challenge remains because drugs were not abundant and traditionally only 3 to 7 days drug supplies were offered. But for a hypertension patient, they need months of supplies. How can they come every 7 days to pick up drugs? So we coordinated, negotiated, mobilized the government to supply drugs in the centers so the patient can have at least 1 month drug supplies and reduce out-of-pocket cost. So after the 2 years of research and trial, we saw fantastic finding both the systolic and diastolic blood pressure at the community level substantially reduced. And this is a significant achievement in all 3 countries. And this study was published in high impact journals, and the analysis of economies also suggested that a country like Bangladesh, we need only $10 to scale up this program across the country in 2 years, and it is such a cost-effective program. But it was not scaled up. But at the local level, there are a lot of impact. Doctors continued their treatment practices. Community health workers continued their screening blood pressure and educating their neighbors. And the government actually adopted the treatment protocol to have a national treatment guideline and develop national guidelines for lifestyle modification. So lots of the good things happened. One of them was, this is for the first time, NSAID drugs were available in all health facilities in the country that is run by a government, what is not thinkable before. But COVID came in 2020, and all these efforts were stopped. And we realized that we, the parachute scientists, come from an organization, land in a country, land in a community. We do the research and go away. Where is the benefit stays? And we realized that it is a complex, health system is a complex, but we need to integrate some element to make it a holistic care ecosystems. While we're treating patients, at the same time, we need to identify people at risk who should be given preventive care so that they don't develop the risk and they don't develop the diseases. Because once the disease is there, it cannot be cured. You have to carry it for lifelong. And we were really looking forward for a auxiliary task force. What can that be? And we found digital health solution. And we realized that maybe digital health can help us augmenting these processes and help us scale up. And what we did, we transformed the entire manual model into a digital model so that every health worker at the community, at the facilities, they can have an apps that they can use for screening, referral, treatment, and monitoring the patient for lifetime. That was an excellent work. But where is funding? So what we did, we looked for different organizations and got very little funding. But we realized that just having a rural solution will not be enough for the country. So we developed an urban solution, which is catered by the health service, catered by another ministry, not by the health ministry. And of the most vulnerable population in the coastal areas, 33 million people where there is no health systems. So how we can make it a comprehensive model for all these communities so everybody benefits from it. But the thing was, this is again, we go down to the communities, do a research and come back. But we need to make an infrastructure and setting and capacity so that data and services are offered on an everyday basis, not by the researchers, but by those people who provide the services to patients on an everyday basis, be it in a community clinic, be in a hospital setting, or in the community programs. We need to build infrastructure and develop capable team to collect data, analyze data, and give it to the managers so that they can actually make decision for improving their care and give benefit to the community. So we came up with research capacity building for the vision of building a lasting, capable leadership team. Okay, so I think I just go for there. But we realized that doctors need to be trained how to do research. And we have a platform of clinical research Bangladesh. And the goal was to teach the doctors how to do research and encourage them to share the research findings. For 18 months, it went well, but when the funding dried, everything stopped because doctors don't have time. They only have incentive for seeing patient. No incentives are given for publishing research. So we realized that we need to revitalize the entire program, not focusing on doctors, but also focusing on other health cadres. And it has to be a system that allows the healthcare provider as identify their own problem and develop some research question, collect data, synthesize data, and collaboratively analyze data and generate evidence for solution, local level solution. So make small change for strengthening their health system so that they can translate those benefits into their everyday routine and improve quality of care. Then we developed a new ecosystem for health research and data science, not in isolation, because we realized that solutions in one country is not adequate. We need to learn from other countries, and countries in Asia, they share common culture, common practices. So we need to have a regional network. So we developed the Global Health Network Asia in collaboration with our partners in the Global Health Network in the UK, in Oxford University. But we did not stop there. We also reached out to the Latin American programs, our colleagues there, and also African colleagues there. And we really look forward to 5 years program for learning research capacity and how to train the health service providers and create a data resource, make reusable data, and strengthen research and data science environment to have a federated global strategic partnership for better benefit. And of course, it is data ultimately that matters, and we created a global health data science. And the mission is to create a champion in each and every country who becomes a member of the network, who will give a drive to look for existing data that is sitting there and try to reuse it to identify evidence, rather reinventing another wheel, and create a collaborative platform and common data repository and build skill to analyze them to have local evidence and again, getting local solution for identifying common problem, common solutions, and identify a path to scale for best practices. And the vision is to get all trained team, empowered community, research governance, and ultimately reduce the NCD multimorbidity through service policy strengthening and for better health. And that is the only way we can reduce morbidity and mortality, and research will be a core activity for that. But just to keep in mind, we just can't be focusing on one population. We have to think through life cycle, and we have to think about all those risk factors that can amalgamate to have NCD diseases in adult age. So this could be a life cycle approach, not only in human life, but also research ecosystem. So each and every health service facility should be brought into the program. So let me show you this picture on the left-hand side. This is the train. Can you see the train? People going home, and this is a common picture. You can't see the train. So this shows how crowded a country can be. And in a crowding like this, after pandemic of COVID, you should be worried, right? People are not wearing masks. They will die if the COVID is there. So you can imagine pathogen doesn't static. Pathogen doesn't have boundary. Pathogen evolve. We are not as smart as the pathogen to beat them, or the conditions in the body to beat them. So we have to unite. And the right-hand side shows the Global Health Network Asia, where we have partners from India, Pakistan, Nepal, Sri Lanka, and Bangladesh. And we are going to look forward to creating leaders who will create the Global Health Network country-level programs and improve capacity of research for improving health service delivery in those countries. With those few words, I just want to remind you that when we talk about One Health, we probably forget about diseases beyond infectious disease. We probably forget about conditions beyond pathogen. There are environmental factors. There are other diseases. So let us unite and think of a new definition for One Health today. Thank you.
Thank you, Alia. Great start to our panel. We're going to take questions at the end. I think basically the organizers felt sorry for Vasi Murthy as the first plenary when he had lots of questions. So we're going to come back to Alia with the rest of the panel at the end, and we'll leave plenty of time for questions there. So let's move on to the panel. And we have a really exciting range of different activities here. And our first speaker is Vivek D'Souza. Vivek is from the Institute of Public Health in Bangalore, India. And he's going to tell us about implementation of tobacco control policies in India. Please, Vivek.
Good morning, everyone.
At the outset, I'd like to thank the Global Health Network Conference, the conference organizers, and the University of Cape Town for giving me this opportunity to present some of the research findings of the work we're doing in India. So the topic of my presentation is the lessons learned from 2 regional consultations on strengthening the implementation of tobacco control policies in India. Tobacco is a global issue having far-reaching local consequences. Tobacco kills around 8 million people globally, and India shares a large burden of tobacco, where tobacco kills around 1.3 million Indians each year. Tobacco use prevalence in India is pretty varied and diverse. As you can see in the map, we have almost 267 million users, current tobacco users in India today, out of which 10.7% roughly smoke cigarettes. A majority of the adults in India smoke BD tobacco, which is a local variant of the tobacco in India. 38.7% of adults are exposed to secondhand smoke at home. And the prevalence of smokeless tobacco use is almost double compared to smoking cigarettes, with 21.4%. So what has India done? India has been a front runner in the enactment of comprehensive tobacco control legislations. It ratified the Framework Convention on Tobacco Control in 2004. But even before that, a year earlier, we had the Cigarettes and Other Tobacco Products Act, or COTPA, in 2003. Starting 2007, the Government of India enacted the National Tobacco Control Program, or the NTCP, which is a governing body that oversees the implementation of the tobacco control laws in the country. And we also have Food Safety and Standards Regulation Act, or 2011, that regulates and prohibits smokeless tobacco use. But despite having these laws, India faces a lot of challenges in implementation. However, what is important to note is that this is not unique to India or to tobacco control. Many countries in the LMICs also face similar, if not same, challenges in several health programs and policies. In India in particular, and in the context of tobacco, there are different and varied forms of tobacco products available. Exposure to tobacco also influences and is determined by your age, your social location, low education and income status, and urban and regional variations. We also have the problem of tobacco industry interference. But more so, implementation of tobacco control policies is hindered by several organizational and health systems challenges. We have fragmented government structures, competing interests in terms of tobacco, where certain ministries or departments are against tobacco due to health reasons, but certain ministries and departments favor tobacco because tobacco is also grown and produced and manufactured in the country, and there is a lot of revenue generation and taxes due to it. There's lack of resources, poor coordination and enforcement, and very little data to review and monitor these policies, and illicit trade. So what did we do? How do we then understand the implementation of the tobacco control laws, and how do we strengthen these? More so, how do we create an enabling environment where both researchers, policymakers, and practitioners come together to discuss and debate how best to strengthen these policies? So we organized 2 regional consultations, and we use this as a method amongst several methods in our 5-year mixed method study. We developed and implemented regional consultations under the theoretical framework of realist evaluation, which is a principle that's based on the understanding that there are several contextual factors when a program or policy or an intervention is implemented. And these contextual factors interact to create several outcomes. So our objective of organizing these consultations was to understand, in Indian contexts, what kind of mechanisms did or did not work, which resulted in different tobacco control outcomes. So we started with a stakeholder engagement process where we identified several stakeholders who are directly as well as indirectly responsible for implementing the law. We used our existing networks and leveraged these networks because the organization used to also previously work on tobacco control advocacy. So we use these networks to identify certain stakeholders and include them in these consultations. At the same time, we had also collaborated with the Southeast Asia regional head of an international organization, which is based in New Delhi. And we started first by sending them emails and then also calling them. For the stakeholders that didn't respond to those emails, we called them again, and then we did a follow-up. We met each of the stakeholders in their states, and then we organized the 2 regional consultations, one online and one in the Indian state of Chhattisgarh. And within each regional consultation, we conducted 4 focus group discussions based on the 4 strategies that are prioritized by tobacco control. One is the awareness, enforcement, intersectoral coordination, and on tobacco industry interference. So these were some of the results. Around 19 states in total in India participated in the regional consultation, both online and offline. The regional consultations were a platform or a space for state-level implementers, tobacco control specialists, practitioners, and people from health, research, and other allied sectors to present their work and to talk about the barriers and challenges that they face. So some of the concrete action plans that were that came out of this deliberative process was that there needs to be a comprehensive manual that outlines the implementation. This manual needs to have ministry-wise or department-wise guidance, and this guidance can help in organizing such meetings, issuing letters from higher authorities, reporting progress to the state-level authorities. Considering that tobacco use is a risk factor for many NCDs, and people who live with HIV, TB, and other non-communicable diseases are also they are faced with the issue of tobacco, there was a realization that there needs to be advocacy across health programs in order to improve and prioritize on tobacco control. States and districts need to be empowered and act beyond the existing laws. There was a challenge in communicating what is tobacco industry interference and why is it a problem. So the underlying recognition was that there needs to be a common language in identifying industry interference and why that is problematic. And the fact that government, CSO, academia partnerships need to be formalized. So these were some of the lessons learned and challenges. Initially, the stakeholders were reluctant to participate because they were unaware of how their participation will help in improving the implementation of the law. Stakeholder engagement requires time and money. And we realized during the process that we need buy-in from senior level bureaucrats before approaching the juniors who are implementing the law. These are some of the lessons learned. Thank you.
Thanks very much, Vivek, and perfect timing. I saw you finish just as the sign went up. So I have to admit, I've been a little careless of chair because I seem to have lost the next speaker on your program. But don't worry, we can move on past that, and we have a great talk coming up from Kuta Banda. And Kuta is with the Clinton Health Access Initiative in Zambia, and she's going to tell us a bit about the implementation of data to policy training. Thanks, Kuta.
Thank you. Good morning, everyone. My name is Kuta Banda, and I work with Clinton Health Access Initiative in Zambia. So the delegation book indicates that I'm from Malawi, but I'm sure my ancestors are from there. So I'm here to just share a few lessons from implementation of the Data to Policy program that we have running in Zambia. So we do know that knowledge translation is really this gap between the know-do gap. We know that in most cases, researchers are going to use quite complex language to communicate their results. And in some cases, we find that decision makers may not be technocrats to be able to understand the odds ratios, the relative risks, and so on. So we really want to bridge this gap to ensure that the knowledge that is being presented is easy to uptake. And in Zambia, the National Health Research Authority has been implementing this program called Data to Policy. We call it D2P in short. And it's a capacity building program that facilitates knowledge translation. And we've seen that at national level, it has informed decisions that have been made. Now, we did realize that at subnational levels, there's very low utilization of knowledge to make decisions. And so last year, with support from Sweden, we were able to, adapt this national program to have a subnational data to policy program, just to adapt it to ensure that we're taking into account the decision-making levels and authorities that exist at the subnational levels. So how did we do this? This process started with having this agreement with the National Health Research Authority. And like I said, we're able to adapt the curriculum that was existing and develop a curriculum that had about 16 modules. I won't go through all of them, but I'm happy to have that discussion as we continue engaging. And so after we developed these modules, we then started implementing with the first unit that involved modules that talked about problem identification, using different tools, doing root cause analysis. And I'm happy that this morning there was a discussion about utilizing routine data, because this program actually encourages identifying the problem from the routine data that we have, and then also conducting policy analysis. And thereafter, it's a mentorship program for 6 months. We then had weekly online check-ins. We had mentors and mentees. And then we also had initial stakeholder engagement. We had to ensure that there's buy-in from the stakeholders from the beginning. They are part of the process of identifying the problem. And I'm happy to report that we had the sub-national officers, the frontline officers, being part of this cohort. And so they are able to identify the local problems that they have, and also to identify the interventions that they think should be made policies to address their problems. After this, we had a second unit. This involved economic evaluation. So we did realize that decision makers, this is quite an important aspect, because they want to know whatever you're proposing, what is the impact, what is the effectiveness, how much money do they need to put into it, and so on. And after this, we continued the virtual sessions and then moved to the more practical aspect of conducting the economic evaluations. And then we had the last session that focused on policy advocacy and communication. And following which, we continued stakeholder engagements, and we had a policy forum at the end where policy briefs were developed. And we're happy to also report that we had parliamentarians part of this. And so it was a very acceptable process, and the recommendations were quite acceptable. What were the results? So we had 6 policy briefs developed from this process. One that was looking at measles vaccination, how to improve that. Another one focused on how to improve antenatal attendance in the first trimester. Another one looking at, iron deficiency and anemia in children. And one that focused on teenage pregnancies. Another one looking at addressing stillbirths, preventable stillbirth. And then we had a last one that looked at intimate partner violence. What are the strategies? What is it that we can implement to reduce this? Some of the challenges, I've just highlighted a few high-level challenges, which is the time commitments that the participants need. So this curriculum was meant to be delivered in 4 months, but we're able to be flexible and run it within 6 months to take into account the fact that these are frontline officers. So they have their day-to-day jobs, and it's quite an intensive course. And then we also looked at commitment of the mentors, particularly the health economists. You would know that most of the participants were coming from the health background. So epidemiology and things like that were a bit easier for them to follow. But when it comes to doing economic evaluation, it requires a certain level of skill. And so some of the mentors were also a little busy, because there's a few mentors in that area. So we tried to have a lot of in-person meetings, bring people together. And of course, that had a little bit of an implication on costs. Yeah, but that was able to get us to the end of the evaluations. And also another aspect was lack of access to certain articles, especially those that looked at effectiveness of different interventions. So there were some articles that required, of course, you to pay to access them, but the team that we had are from a public institution. And so being able to pay for access to those articles was a challenge. So we're able to use the articles that we could find. And in some cases, when building our models, we're able to note that these could be the limitations if it's not very close to the context, to our local context. So our next steps from this program is, now that we've developed these policy briefs, we've presented them to the decision makers. The decision makers are happy and they would like to see these interventions done, but we now need to look for resources to be able to actually implement them in our settings and see how effective they'll be. And also would like to roll this program out to, more frontline officers, would like to have more nurses, clinicians from the health facilities, because then they get to appreciate the importance of the data that they are collecting, the routine data that they are collecting, and they feel like they are part of the solutions, because them being on the ground, they do know some of the interventions that would work. So we want to roll it out to those frontline officers. And would also just recommend some level of access to, a lot of journals, especially for those in the public sectors, because we do know that funding in the public sectors is quite a challenge. So asking me to pay $300, $400, it's not something I can easily do here. And then also, if anyone would like to implement this program, it's quite a good program, especially if you are bringing in the frontline officers themselves to develop their own policy briefs, walk through the process to develop the interventions that they would want. So it's just important to set expectations of the time that is required. It is an intensive course, but it is quite acceptable, and setting those expectations from the beginning for the mentors and mentees is important. I would like to acknowledge the National Health Research Authority, Sweden Ministry of Health, the CDC Foundation that worked with the original curriculum, Vital Strategies, and the Bloomberg Data for Health initiative. Thank you.
Thanks very much, Kuta. So our next speaker will be Elodie Chevalier. And Elodie is from the Institute Pasteur in Madagascar. And she's going to be talking us through the really interesting challenges of improving prison health in Madagascar. Thanks, Elodie.
So, hi, everybody. I will present you today as a process that we made to help improving prison health in Madagascar through knowledge translation, and what innovative and challenging it was. So first, let me introduce you prisons in Madagascar. They're overcrowding by more than 400% of the capacity. There is also a problem of limited access to water, with poor sanitation infrastructure, water cuts, and all of this increase the risk of communicable disease. There is also a big problem of food access. The penitentiary administration provides only 300 grams of manioc per person per day. So this has led to 30% of chronic malnutrition and all the related disease, as tuberculosis. There is also a limited health access. There is no doctor in the prisons, only nurses, and a very low ratio of caregivers to inmate. Actually, there is more than 30,000 prisoners in the country and only 60 caregivers in prison. So it's in this the MIAN project takes place in this context with the aim of contributing to the improvement of the overall care of tuberculosis and HIV infection in prison through 3 components, including investigation. So one of the strengths of our project is that we work directly with different partners with all different expertise. So we first begin by a qualitative study on the healthcare pathway. One of the main results of this study was to highlight the role of unofficial actors in the healthcare pathway. Due to the lack of caregivers, prisoners called corvées are supporting the infirmary activities. They have a lot of tasks that I will not detail right now. And they are quite similar to the community health worker in the general population, but they have no basic health training and they're never a target population for the health activities. So then at the end of the study, we disseminated the scientific result for a restitution workshop with all technical and governmental partners working with us. So usually it's where studies end, but it's where the knowledge translation process really begins.
So together, we co-formulated concrete recommendation based on the scientific result of the study. We all agree to the urgent need to train the Corvée and formally recognize their activities in the healthcare pathway in prisons. But at this point, we were totally helpless and we had to ask for a financial support to get help from international experts in knowledge translation. They could help us to train our team for capacity building knowledge translation, and they also help us to elaborate a knowledge translation plan. Then they also help us to elaborate a policy brief during a workshop who implicated all the actors in the prison health sector. One of the most difficulties of this elaboration of the policy brief was to find an impactful message to spread and the right target audience to pass to. So this is why our policy brief looks like. And it was also hard to find a consensus on the terms to use. We couldn't not use specific terms as Corvée to be understood or use controversial statement as Justice Ministry did not allow us to say that the Corvée are essential in the health pathway. So then, in the meantime, we elaborate the training of prisoners involved in the health. So first, we did a need assessment with inmates involved in healthcare and prison caregivers to determine their needs. Then on this basis, we created training modules and tools with all the actors involved. According to the needs assessments, 2 topics were covered: first aid and symptom recognition of the most frequent disease in prison. We also elaborate visual tools designed for prisons, and we disseminate it. At the end, we train 240 inmates and 33 prison officers. So, since the purpose of this project is to create new activities to improve health in prisons, it is necessary to evaluate the impact of the training. And this evaluation is ongoing actually, and is being done with the help of the expert team. So I can tell you more right now. But of course, all the results will be shared with all the actors and will serve as a basis for the Justice Ministry to expand the training of the other prison. Our project, the knowledge translation process, will end with a final workshop, bringing together all the stakeholders, prison health decision makers, and future funders. And the purpose of this workshop is to disseminate the policy brief, to share our experience, and to highlight the priorities to guide future projects in the light of the lessons that we learned. So it was supposed to take place 2 weeks ago, due to a lack of communication, it was postponed. So what should we learn from this process? First, it is really important to plan the knowledge translation process from the very beginning of your project. You have to plan a budget and a timeline. You have to involve the stakeholders. I will tell it again and again, but it's one of the most important things. And you will have to design the translation knowledge plan together. And it's also really important to evaluate the activities impact at the end. You will have to train also teams and the key people of the project in the knowledge translation. Then you will also have to think about the continuity, what seeds to sow. So for example, in our project, it was a final workshop, was a good method to suggest solution behind the project. Oh, it will, because it's not happened yet. And be careful and be aware. This is a time-consuming process, so do not underestimate it. And it's also an inductive and participative approach. Engagement of all partners, it's necessary to make an impact. Researcher, government agency, and civil society organization. So pay attention to distribute tasks between all of them. Thank you.
Thanks, Elodie. Fascinating. So for our next talk, we're moving to Farah Nabil. And Farah is from the Universidad de Zaragoza in Spain. And she's talking about promoting health and gender equity through research ethics capacity building. Farah, the floor is yours.
Thank you.
Hello, everyone. I'm very happy to be here with you today and to present my experiences in promoting health and gender equity through research ethics capacity building in the context of a Spanish-West African collaboration. So first, let me give you a brief overview of the ethical imperative of integrating sex and gender-related variables into health research. There is a significant body of evidence to show that sex and gender affect health outcomes on a population and on an individual level. So therefore, for research to be inclusive, rigorous, and reproducible, we need to include said variables. In the case of West Africa, for instance, we saw that after or during the pandemic and the Ebola epidemic, gender inequalities were perpetuated and exacerbated in terms of socioeconomic deterioration, increased rates of intimate partner violence, and lack of access to sexual and reproductive health services for women and gender minorities. So why is capacity building in research ethics pertinent now more than ever? We saw that after the onset of COVID-19, there has been a surge in research conduct in West Africa and all of the African continent, really. So this means that research ethics committees or RECs need to be capacitated to identify research that has no scientific or social utility, but also research that is gender blind or gender discriminatory. And we also need to go beyond sex and gender and focus on health equity as a whole, focus on other intersectionalities, meaning variables such as ethnicity, race, skin color, religious affiliation, disability status, sexual orientation, for instance, and see how they interact with health inequalities. And this can be tackled by ethics committees through a health equity impact assessment during routine protocol appraisals. So now let me introduce the project in the context of which this collaboration takes place. This is an EDCTP funded project. The first phase was kicked off in August 2019 with Senegal as our partner. And now in this second phase that is kicked off in April 2021, we are 4 countries, namely Spain, Senegal, Benin, and Mali. And we are collaborating with countries all over West Africa and with the Africa Bioethics Network based in Nairobi, Kenya. And our objective is to build the capacities of bioethicists and research ethicists in sex and gender mainstreaming and research ethics, especially in a context of health emergencies and a clinical research setting. And on the left, you can see the map of the project stakeholders, especially the project consortium and the advisory board members. You can see that we represented in 8 different countries between Africa and Europe. And one of the key dimensions of our project is capacity building initiatives in sex and gender integration methodologies into research ethics. So as you can see, we've done many virtual trainings over the past 2 years to allow bioethicists from all over the region to join us live. We also implement in-person capacity building activities, the last of which was a gender mainstreaming and research ethics internship that took place at the Aragon Research Ethics Committee in the University of Zaragoza in Spain for 7 bioethicists and regulatory officers from Benin and Senegal. And it was a very rich opportunity for knowledge sharing about the different realities of bioethics in the different regions. So in terms of where our participants are based, our capacity building participants, you can see that they're based in many countries in Africa. We have 14 different countries on the map, and we estimate to have trained over 200 bioethicists in the last 2 years. And in terms of gender parity, we see that it is slightly skewed towards male representation with 53 to 47% respectively between males and females. So we're almost at a 50-50 ratio. And prior to kicking off our capacity building work package at the second phase of the project, we had a needs assessment all over West Africa for national research ethics committees. And it was clear that there is a strong need for training in sex and gender integration in research ethics, but not only in terms of research evaluation, but also in terms of governance, such as gender equality planning, monitoring, and evaluation. We also have a virtual Research Ethics Secretariat that offers free technical assistance and support to all national ethics committees all over West Africa. And we are currently working with 7 different countries. And we're happy to say that after 2 years of work with Senegal and Guinea-Bissau, they have mainstreamed the gender-sensitive standard operating procedures, tools, and guidelines that have been elaborated with the help of the project, and they are now implemented nationwide and approved by the Ministry of Health. We also produce open access guidelines, policy briefs, and toolkits in Portuguese, English, and French to make them more accessible on integrating sex and gender related considerations and variables into research design and research evaluation. And we make sure that our content is context specific because it is mostly for the West African context and the African context as a whole. So we make sure that it is context specific and takes into account the sociocultural nuances of the region. In terms of challenges, first of all, changes in practice and policy in terms of gender mainstreaming into SOPs or guidelines is a very lengthy process due to bureaucracy, but also due to the dependency of national research ethics committees on their host institution, meaning the Ministry of Health in this context. We also saw some resistance to gender mainstreaming as it was often conflated with the promotion of homosexuality, for instance, gender and sexual diversity, which are taboos in the project-specific region. There was also occasional rejection of the foreignness of the gender mainstreaming concept, deeming it imported, Western, non-African, etc. And we saw that there were gaps in knowledge between researchers and ethics committees in terms of sex and gender in research design. And it hasn't always been easy to engage the presidents and directors of the different ethics committees in the needs assessment research that we conducted prior to capacity building activities. In terms of recommendations to address the challenges, we recommend advocating for the autonomy of the ethics committees so that they can be able to make their own decisions about gender sensitive operating procedures, for instance. And also to adopt culturally sensitive strategies for gender mainstreaming advocacy with emphasis on African leadership to increase the acceptability of the concept of gender mainstreaming in research in that context. We also need to establish synergies and networking platforms between research ethics committees and research institutions to close that knowledge gap that we talked about between researchers and research evaluators. And this can be in the form of training, networking events, communication and dissemination on part of the research ethics committees and so on. And lastly, we also are trying to implement and reinforce an online culture, quote unquote, for research ethics committees in order to facilitate protocol submissions, especially in times of health emergencies such as COVID. Yes, thank you. That's all.
So thank you very much, Farah. So I apologized earlier for losing a speaker, but now I can redeem myself by giving you 2 for the price of 1. So we have now a special offer on our next speakers. So Goodness Odi and Madonna Badam. Goodness is from the University of Calabar, Nigeria. Madonna is a youth advocate with UNFPA, and they're going to talk to us about improved access to youth-friendly sexual and reproductive health and rights services. Thank you. Over to you.
Hello, everyone. Good morning. So my name is Goodness Odi, and we are here to present our abstract titled Towards Achieving Improved Access to Youth-Friendly Sexual Reproductive Health and Rights Services in Cross River State, Nigeria, through the Sustaining Evidence-Driven Advocacy Project, where we developed the first ever Cross River State Sexual Reproductive Health and Rights Policy.
Hi, everyone. My name is Madonna Badom. I'm a youth advocate and was an advocacy associate for the project too.
So we began the project by carrying out a survey in 2019, and this was conducted in Nigeria in 3 states, in Anambra, Cross River, and Abuja. This survey was to enable us to understand what are the challenges and the gaps that exist when it comes to youth-friendly service provision for young people. Specifically in Cross River State, Nigeria, where we carried out this project, we discovered that young people experience limitation when it comes to accessing youth-friendly, non-discriminatory SRHR services. So the major component of the SEDA project was youth policy advocacy and youth-friendly SRHR service advocacy. With this survey and the findings, we concluded on these problems that the limitations when it comes to youth-friendly service provision was as a result of lack of reliable and clear information. Also, providers' discriminatory judgment. So we saw that many service delivery workers, health workers, there was discrimination and judgment when young people want to access these services. Then there was no confidentiality and privacy when they want to access these services. And the FP programming was not inclusive in terms of young people being involved in the design and implementation of the programs that affect them.
So what we wanted to do next, following the findings we had, was over a period of 13 months, we put together a 5-man team to domesticate an SRHR policy in Cross River State. Now, that policy was going to be focused on the youth rights, addressing the needs for access to safe, effective, and non-discriminatory, affordable youth-friendly services across health centers in the state. Now, we did this through, first of all, consultative visits to high-level stakeholders in the state, the Commissioner of Health, the Director General, Primary Healthcare Development Agency. We also visited the Family Planning Coordinator, and we put together a multi-stakeholder approach, which was focused on CSOs working on SRHR, young professionals, people living with disabilities, and these high-level stakeholders. The goal was to make a team together that was inclusive and would come together to draft this very amazing policy for us. So the next thing we did was we had policy drafting meetings. Here, this was like the first meetings we had with our stakeholders. Then we had series of meetings, reviews, validations, and the rest of them. And at the core of all these meetings was that this research findings that we made was going to be translated into policy that would be used by healthcare workers, by CSOs, by partners, whoever is doing SRHR services in the state would use this as a reference to inform their programs and include young people and improve access to young people for youth-friendly services. And as we can see here was the policy validation and launching meeting. That was the last step of the process. We printed over 1,000 copies and distributed to primary healthcare service centers through the Ministry of Health so that it could be used for young people.
So what changed? Because it is very common, especially in Nigeria, where we have a lot of amazing policies, but these policies does not translate into action. Since the launch of the Cross River State Sexual Reproductive Health and Right Policy in 2021, we have seen and have been engaged in increased advocacy and resource mobilization towards improved youth-friendly service provision for young people and looking at a holistic approach where there is government engagement and private stakeholders engagement. Also, the multi-stakeholders approach which we utilize from the evidence generation phase of the project to the policy drafting and launch has also been instrumental for the adoption and utilization of the policy, because we've had various stakeholders reaching out to us to get that policy to use in the work they do.
And while we were doing this process, we were faced with a lot of challenges as usual. One of them was steering bureaucratic structures in domesticating an SRHR policy. For example, we needed approval at every stage from high-level stakeholders like the Commissioner of Health. We couldn't move on to one stage without her approval, and that was a strain to us. And then dynamics of a multi-sectoral stakeholder partnership. Like I mentioned, we had a lot of stakeholders, so navigating those dynamics to get them on board with our objective was an issue. And then we had resistance to change by health workers who were challenging the norms in the state, so we had a lot of resistance to that. And then escaping ambiguity while formulating the policy. We didn't want a policy that was so much that was too much languages, too much information that would not translate into practice. So those were the challenges we had. And how we were able to solve them was we went digital with the Commissioner of Health. We're so grateful for our help. We recommended that we take some of our meetings online. So most of the approval she was giving us was through mail, which made it very easy for us. And then a multi-sectoral partnership, we had to cut down the stakeholders that were involved in making the policy editing, policy review. But at the end, the full house came to validate it with the stakeholders, the government and the rest of them. And lastly, the policy was heavily focused on training and retraining of healthcare workers. That was the core of the policy, because we wanted these health workers to change their attitude towards young people accessing SRHR services.
Conclusively, these are our recommendations. Research played a key role in developing this policy, and the action being taken are based on the evidence we have generated. So we are saying that there should be more involvement of young people in whatever you are designing. And this does not just end with young people. Whatever policy you are designing, the population targeted should be meaningfully engaged. Also, partners working at the state and local government level formed a multi-stakeholders partnership committee, which have been critical to continuous engagement. So we had like an accountability group where there will be continuous review of the engagement that has to do with young people, youth-friendly service provision, sexual reproductive health and rights. So we believe that this work is critical, and in the course of the SEDA advocacy project, it didn't just end with the policy, and we hope that we can get more funding support to see how there is continuous engagement, especially with the community health workers, on how this policy leads to more actions and continuous engagement. Thank you very much.
Thanks very much, Goodness and Madonna. Great talk. So that brings us to the end of our panel. I'll try very briefly to sum up a little bit, though I'll leave more time for questions than doing that. But I think it's been a fascinating session of really practical boots on the ground work and showing how research and policy happens in the real world. We've been in the countryside in Bangladesh, looking at the use of community health workers in reducing hypertension with fantastic results there, and then flipping to a very different environment with prison health in Madagascar, and a fascinating study using the training of prisoners to improve their own health there. We've seen tobacco killing 8 million people per year in India, shocking result, and the resistance by those who have got a vested interest in selling tobacco to change, and some of the issues around advocacy for that important person. On a similar theme, really trying to get data to policy and training. And we saw a great talk from Kuta on creation of policy briefs, the importance of mentorship, and of course that plea for greater open access and making sure that the work of the implementers gets out there. And I think we've all found that any of us who've worked in implementation research, you know, it's very hard to get that published. It takes time, it costs money, but we really need to think about the system to make sure that we're looking at real impact rather than impact factors as we go forward. And in the final two sessions, really starting to look at groups which are often neglected in policy. Really important topic from Farah on research ethics around gender inclusiveness. And, you know, we've all seen in the COVID trials, the lack of representation in those trials, and the importance of being representative across both gender representative and geographical representation in those trials. And finishing off with a fantastic talk by Goodness and Madonna. And if anybody wants to tell you that researchers and practitioners can't have a good conversation with advocates, they should watch this performance on YouTube. I think you should take up doubles tennis with such a smooth interplay, but a really important message there about multi-stakeholder, multi-sectoral approaches to engage youth in policy and make them drive policy. So I hope I didn't leave anybody out there. I think we covered the table, but it's now up to you, and I'm happy to take questions. The microphone's on this side, but I will try and make the microphone run. Do we have more than one microphone? Okay, so I can swap sides, please. So.
Thank you. My name is Yasu from Addis Ababa University, Ethiopia. My question goes to Ms. Nebel from Spain. with regard to, I think you have recommended that the ethics committees have to be independent fully, as well as autonomous. So long they are under institutions, do you think this will be realistic to bring them down to full autonomy? Aren't they going to be influenced by the institutions which they belong to? Thank you.
Thanks. The acoustics are a little difficult in here. I think we might have to all speak up at the microphone. Did anybody catch the question? Sorry, but I'm going to have to ask you to repeat the question, maybe speaking a little bit louder. It must just be the acoustics up on stage that's
Apologies for not being heard. My question is, in your recommendation, you put that ethics committees have to be fully autonomous and independent. I believe these ethics committees are under institutions. So would that be realistic? So long as they belong to a given institution, are they going to be fully autonomous and independent? I hope I'm heard now. Thank you.
Did somebody catch that?
So if I understood your question correctly, it was regarding the autonomy of national research ethics committees and their dependence at the moment on ministries of health or national institutes of public health. And your question was, do I think that full autonomy could be achieved at some point? So it is very difficult. It's very challenging. For the time being, we do not work with any ethics committee that is fully autonomous, nor in terms of funding or in terms of being able to approve the technical documents, the standard operating procedures, without it going through a department of the Ministry of Health at least. But we are advocating for it because this gives the ethics committees the ability to be truly independent, because this is in their mandate. They are supposed to be independent organizations, and they are supposed to have the opportunity to raise funds, and they are supposed to have an independent funding line in the state budget. So for the time being, all we can do is advocate for it, produce policy briefs that talk about the advantages of having autonomous ethics committees, even partially autonomous, not necessarily fully autonomous. And we hope to see it implemented in the future. I hope I've answered your question.
Let's take a question from this side at the back first, then we'll move down to the center.
Sorry. Good morning, everyone. My name is Sandra Chilengi from Zambia. I have a question for the presenter on gender and health equity. My question is regards understanding how successful your project has been. And in trying to understand, I want to know whether or not you had any monitoring and evaluation plans. I want to believe that that would be one sure way of seeing or establishing the success of your project. So did you have any such programs, and how did that work? Thank you.
Thank you for your question. Let me just repeat it back to you to make sure that I got everything. So you were asking in terms of how successful has the project been so far, and what are our monitoring and evaluation strategies, is that correct? Okay. Yes, we do have a monitoring and evaluation plan, of course, in terms of deliverables, objectives, indicators, and we have a target for each indicator, and we see to what extent did we meet our objectives. So the first phase had ended on the 31st of July, 2021, and we were able to meet all our objectives. We submitted 100% of the deliverables. We targeted the countries that we were hoping to target. In terms of limitations or shortcomings, we had more engagement from the French-speaking countries than the English-speaking countries, because we were mainly collaborating with Senegal, so we were able to create networks within Francophone countries, but had a very limited participation with English-speaking countries. We also had very active engagement from Portuguese-speaking countries, so that may be one of the indicators where we fell short. In the second phase of the project, we are working with more countries. We are trying to be more regionally diverse and to pay attention to English-speaking countries as well as Portuguese-speaking countries. And we also noticed that the Francophone countries are far more engaged, but we have been able to include more English-speaking countries. We have been able to target more countries. As you saw on the map, we engaged 14 different countries in terms of participation. We also increased gender parity, because before it was almost 2/3 of our participants were male and only 1/3 were female. So now we increased in terms of gender parity. And so far, in terms of our monitoring and evaluation, we are following the plan. We are meeting our objectives. Our deliverables are all in place. So this is what I can tell you for now. And if you were asking about a specific evaluation methodology, it is pretty standard. So we have our objectives, our indicators, our targets, our timeline, and we just follow up on that and see what needs to be done. And try to continuously improve based on the gaps that we encounter and the challenges. Thank you.
Thanks. I saw the person with the orange scarf here first, then I'll move to the center for the next. So I see you and you, yeah.
Many thanks to our presenters. So mine is not a question, it's more about clarity to Farah. Thank you for all of the great work you've been doing with Ethics Committee. So back to the first question that was asked. I think Ethics Committees, they are autonomous. I'm from Liberia. I'm Gloria Maisie Ross from Liberia. And even though they have their own challenges in terms of fundings, but when it comes to decision makings, they are autonomous. They are independent. And I think one of the things that is missing is the issue of hands-on evaluation to know what is it that these committees face and what are their on-ground challenges that they face. I think with that, then you better understand, but in terms of they are nominated, yes, they are autonomous. Thank you.
Really sorry, it's the acoustics of the room, but could you just try and repeat the middle part of your question? We didn't catch it. Apologies.
So it's not actually a question, but I just want to make clarity to the point of the anonymity of an ethics committee. So I was saying that they are autonomous when it comes to decision makings and some of the work, but in terms of the finances or the sustainability, they have some challenges, but they don't depend on the Ministry of Health in terms of decision, whether it's gender or whatever means. They don't depend on the Ministry of Health. So I just want to make that clarity. Thank you.
I think it was a comment. Yeah.
Thank you.
Just a comment. It's a comment.
Yes, I don't need to react. Oh, okay.
I promised the gentleman there about 2/3 of the way back. Then I'll move down to this row and then we'll move over to the other side. Sorry about that. It really is difficult for the presenters to hear in this room. It's almost impossible for us to do it. So we are apologizing to.
Good afternoon, everyone. I am Elvis from Cameroon. First of all, I would like to commend Goodness and Madonna for the very excellent presentation. I just want to understand something because, I mean, this is very interesting to see how young people take ownership of addressing a problem that is very important for their well-being. So the survey that you did, was it like an interviewer administered survey? And if that was the case, how what was the type of reaction you had from your peers when you were asking them some questions about their sexual and reproductive health and rights? Considering the fact that most of the time it's more or less a taboo to talk about that, especially among young people. And then the second part of my question is that during the stakeholder consultations that you did, what was the reaction of the different stakeholders when you had to discuss this with them? Because most of the time we are used to the conventional way where relatively older people talk about the problems of young people. How did they react when you came to talk about your problem to them and then trying to tell them what you think could be the way forward? Thank you.
Thank you for your question. So I'm just going to respond to the second question first, then my colleague will take the first. So the reality is that in many cases, you would see a lot of opposition when it comes to sexual reproductive health and rights and for young people. But interestingly, the stakeholders we engaged were firstly civil society organizations who were pushing sexual reproductive health and rights in the states. So in most cases, these people stood for young people access to SRHR. This does not mean that they did not have their own personal bias, because we see a situation whereby I'm pushing for this because this is my job, but I also have my religious bias or my cultural bias when it comes to sexual reproductive health and rights for young people. So since it's a multi-stakeholders engagement where we had the government, family, the Ministry of Health, the Primary Healthcare Development Agency, young people, we had a way to navigate balancing different perspectives. So when you were bringing your personal bias or religion, we were able to work around the conversation to say, please, let's focus on the objective and also educate such a person to work around their bias. So that was really key for us in terms of the bias. Then we also had engagement with the family planning coordinators at the community level in Cross River State. And interestingly, even though these were health workers, we also got their bias when it comes to young people accessing sexual reproductive health and rights services. And they told us that they don't even have the capacity to provide youth-friendly service. So they don't even understand what youth-friendly service provision is. And they don't know the importance of young people accessing youth-friendly SRHR services. So these gaps were useful for us as we gathered all this information and data and then led to development of the policy. So my colleague will respond to the second question. Okay, so the first question was what kind of survey was carried out? Well, we had a survey with young people made up of girls and boys and girls in the States. Most of the survey was also online. We used this Google Forms, thank you. So we used that it was all anonymous. But one of the key ways we got our information was through our key informants interviews with most of people, health workers working in the states. And that was done by, this research was carried out by PRB and IYFP. So it was very extensive and we made sure we went through all the rules and that was how we got our data. Thank you. Thank you.
Thanks. I think given the time left and the number of hands, I'm going to take the prerogative just to ask one last question down the panel, and apologies for those who haven't had their answers, but the panel will sit around afterwards and I'm sure they'll be happy to take you on, but it's just not going to be possible to get round in 5 minutes. And I wanted to make sure that everybody got a chance to speak. So I'm going to ask them for the 30 seconds of wisdom here for people out there who want to make a difference, who want to make sure the evidence gets translated into policy. What's the main lesson you've learned from the work you presented us today? Alia.
I would say ownership. Until and unless the community or the setting, they don't feel as a part of this research or the problem solution paradigm, they are not going to adhere to any solution and it is not easy to uptake. That is, ownership needs to be happening at the very grassroots level. But also at that top-down approach, ownership is very important, and that ownership has a different form, like the government. Without government support and system support, no benefit can be translated or sustainable or scalable for the longer term. And maybe the government's ownership has to be different in a way of investing in
research. So if government can invest in research, they will like to see output of it. And this is how we need to do both community ownership and also government ownership at the same time. Thank you.
Very wise. Bye-bye.
So I think research has to be context specific and also community led and also practitioner led. In our regional consultation, what we realized that the stakeholders who represented different states, they had very different contextual contexts, despite coming from the same country. Different kinds of barriers existed and different kinds of learning points and takeaways that they could learn from each other. So that's one thing that I would suggest. And the other thing is that the context that is central, that has to be that has to be the determining factor on designing research programs, designing projects, and also implementing them.
Kata.
So for me, I would say that having the people who the policies are targeted at, being part of developing the policies themselves is actually quite key, because one, they get to understand the importance of the data that they are collecting. They get to put in more efforts. And also, once this policy is enacted, they'll be happy to implement it because they were part of the process from the beginning. So I think that would be a key takeaway for me.
Elodie.
So for me, it's, as Kuta said, it's involving many partners with from the beginning, and we all have a different expertise. So we can build together something from the beginning to make a difference. And it's also really important to involve several hierarchical levels. For example, for the Justice Ministry, we did the mistake to involve only technical person at first, but in fact, you have to go by yourself from the top of the institution, and also with technical partners. It's really important when, especially when you arrive at the end of the process, and you have to involve the stakeholders.
Thanks, Farah.
So I would say if you're working in the context of a multinational project, especially between low resource and low income and high income regions, to make sure that there is equitable and fair partnership practices in place in terms of resource and benefit sharing and decision making. And also we need to work on a solid communication and dissemination plan for our findings that is culturally congruent, that takes into account the different barriers to knowledge reception and retention between the different population groups, so that everyone benefits from the findings. Thank you.
Thanks. Goodness.
I'm just going to strongly reemphasize the importance of inclusivity, which came out strongly in the SEDA project. So we can't say we are targeting a particular population through our research and our actions without including them. In addition, the importance of shared interest and distributed leadership. As much as we needed the government's buy-in to push for that policy because it is a government-owned policy, we had to see how the interest of the funders, the interest of young people, the interest of the government was aligned for us to achieve the objective of the project. And distributed leadership is important because after the policy has been developed, what next? The actions that needs to be taken and continuous engagement. Thank you.
Thanks. And the final word for Madonna.
Okay, so what I would suggest is that as researchers, as people working to put research into policy, not one size fits all. You should be innovative, find innovative solutions to your problems, because these problems would always arise. For example, we had so many issues and we had to be very creative with guidance from the government, with guidance from our funders, from our country managers. We were able to navigate this. And also, another thing we were very strong we strongly believed in is that we didn't want an ambiguous policy. Our policy is not up to 100 pages. So it's something that it's a booklet anybody can pick up and understand with clear and concise information. So that is why it has had success with people using it from CSOs, partners working on SRHR in the state, and even healthcare workers. So those are the two things I would like to add. Thank you.
Thanks, Madonna. And so all it leaves me to do now is to finish by asking for you to show your appreciation to a fantastic panel. I think Trudy will now tell us about lunch, but of course, in the spirit of what Trudy said earlier, if your questions did go unanswered, why don't you come up and walk one of the speakers to lunch and have lunch with them?
Thank you very much. John, brilliant chairing, of course. And what a wonderful panel. You just, that was just such a great session. So thank you all. Thank you all for keeping to time. It's lunch break now. Please can you be back in here 10 minutes before the session begins at 2. That's right, isn't it? 2 o'clock, checking with the team. So make sure you're back in here 10 minutes before so we can start on time. Really great timekeeping today. The only other announcements is for the people who are coming to the LAC meeting. So the welcome team and the LAC collaborators. We are in room 4C and lunch is there. So you just go straight to room 4C without any hesitation, deviation or repetition. Thank you everybody for a brilliant morning. I'll take you a little. Thanks everyone. Thank you again, panel.
hey. Check, 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 hey, check, 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 hey, 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 check, 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 and check, 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 switch.
du mal, s'il te plaît, n'y pense plus. Il a souillé ton âme, toi tu t'es battu. Ton cœur est plus précieux que de l'or. Ne pense plus à lui. Pour un homme, tu ne veux plus voir le jour. Des milliers d'entre eux rêvent de te faire l'amour. Ton corps est aussi beau que l'or, que l'aurore. Encore tu pleures pour une histoire de love. Ils vont encore dire que t'as qu'ils ne parlent que d'amour ou d'amour. Mais c'est toi qui demandes à être consolé. Yeah. Moi je suis ton ami et les amis font ça toujours. Donc on va parler. Tu t'es plié en quatre pour un salaud. Et pour vous tu t'es donné sans compter. Lui il a planté le couteau et il a regardé ton sang couler. Et depuis tu ne sors plus. J'ai demandé, on m'a dit tu ne manges plus. Yeah. Mon avis tu voulais. Oh, ne pense plus à lui. Tu fais du mal, s'il te plaît, n'y pense plus. Il a souillé ton âme, toi tu t'es battu. Ton cœur est plus précieux que de l'or. Ne pense plus à lui. Pour un homme, tu ne veux plus voir le jour. Des milliers d'entre eux rêvent de te faire l'amour. Ton corps est aussi beau que l'or. Que l'or. Tu veux ta mort, tout ça pour un petit fils de yeah. Je n'aurais jamais pensé qu'une femme comme toi puisse tomber aussi bas. Tu l'aimais, lui il t'a fait payer. Aujourd'hui tu le maudis. Moi c'est toi que je maudis et tu vas comprendre pourquoi. Personne ne t'a forcé à rester. Non, non, personne ne t'a forcé à rester. Tu étais tellement fier de vous, fier de vous. Aucun homme ne pourra te faire tomber. Non, non, aucun homme ne pourra te faire tomber. T'es la fille de ta mère, le bijou de ton père. Il est qui? Il est qui pour te faire pleurer? Ne pense plus à lui. Tu te fais du mal, s'il te plaît, n'y pense plus. Il a souillé ton âme, toi tu t'es battu. Ton cœur est plus précieux que de l'or. Ne pense plus à lui. Pour un homme, tu ne veux plus voir le jour. Des milliers d'entre eux rêvent de te faire l'amour. Ton corps est aussi beau que l'or, que l'aurore. Encore tu pleures pour une histoire de love.
Body they draw me like a bono. Body they rise in my tono. I say color your procoto, no good this locoto. Kelly de bossy my pololo. Can make a salute your commando. Girl, if you balance Diego, I give you paper. No go do me Diego, my Maradona. Girl, if I lap your sueto, I'm a farisa. Girl, your back keep it connected. And I can follow your cresco. Sunday, dale creso. Pay for your waist, and I could pay for your lace. Pay for your waist. Sunday, dale creso. Pay for your waist, pay for your lace. Palaciego, I did paper. No go do me Diego, my Maradona. Kelly Falapio Sueto, Mama Farisa. Kelly Abaki Picaneto, and I can follow your Cresco, Cresco.
I don't think it's pointing. Yeah, there you go. Yeah, you want to try? This is just X sample power. Yeah. Those ones, right? Oh. Right, so I think we're going to go ahead and get started. So good afternoon, everyone. Such a pleasure to be with you all today. So thank you very much, Trudy, for inviting me and to inviting me to chair. And I think, what wonderful talks we've had so far this morning. And, we're going to sort of build on that in this session. Quick introduction. So I'm Sally Nicholas. I'm the head of health systems within infectious disease challenge area at the Wellcome Trust. And I will be your chair for this post-launch session titled Enabling Health Research in Every Healthcare Setting. Like the talks earlier today, we'll have the plenary first, after which we'll have an opportunity to ask questions. And then we'll have a series of consecutive talks. And I'll ask you for those talks to please keep your questions till the end. There's a slight change from the agenda as Shafiq Makumbi and Dr. Nadia Tago unfortunately aren't able to join us today. So the presenters today are going to cover a nice breadth of geographies, but also breadth of topics from building networks for data sharing to capacity building for AMR. But they present, I think, some common themes around the challenges and opportunities that exist in conducting research across various health settings, particularly in resource-poor settings. And hopefully we can dig into that a bit more at the end of the session. So without further ado, I'm going to move on to the plenary session. And I'd like to introduce Dr. Thomas Narinda, who will be giving the plenary talk. And his talk is entitled EDCTP Connecting and Building Research Excellence Across Africa. So over to you.
Thanks, Sally. I can't resist to welcome you again to Cape Town, in this beautiful town. When you're in a rich man's house and guests come in, if you're all taken up by this excitement, you forget it's not your house, and you keep saying, oh yeah, welcome, welcome, and say, yeah, but that's not your home. You say, it doesn't matter. So welcome again. And I'm really excited to be here. And I must also say, we should all be excited because it's really exciting to work in Africa. And this continent has a lot to offer. I don't know how many people believe that Africa has a lot to offer in terms of shaping the global health agenda. I don't know. Yeah. Oh, lots of hands. So thank you very much. And so I have a presentation just to show you how EDCTP had the philosophy of putting together networks in Africa and how it fits in the environment. And I think it's also a great lesson to many funders because this is a learning process. I don't think there's any funder in this room that can challenge us that they have done it all and they know how to set up networks and this is how it should be done. We are all learning as we go along. So, as I say, Africa is a great continent. Biggest genetic diversity you can find. Just across the border in Namibia, If you've been there, you find there is Caucasians of German origin, African, like me. There's the Bushmen, and there's South Africans, of course, there. And it's very difficult to say that if you do a trial in Namibia, whatever you're going to find is going to be generally applicable to all that live in there. Africa is a great example of One Health, the interaction between environment, people, and animals. I don't think you can get a great example like that. Africa is predominantly the youth. Africa has the biggest burden of diseases, a lot of unresearched populations. I am Malawian, and you can see from that slide, I am 50 years of age. I was born when the under 5 mortality rates were that high. So basically, 2 of my Malawian that I was born with on the same day did not see their 5th birthday. I don't know how I survived. My mother can't remember how many vaccinations I completed. A lot of diversity. You know, I am unresearched. I've never been conscripted in a trial, yeah? But I think I'm an eligible candidate for so many things. And so are a lot of things. I was looking at Pontiano and think, I want to ask him the same question. Do you know that you're probably not fully vaccinated? But I'll ask him at dinner today. Okay. But to say that around all these advantages and opportunities, we don't have problems, is deceiving ourselves. I don't know how well you can see this slide from WHO, but our countries have the least number of full-time researchers per million population. Most of our countries have 7 people. The rest of us are just part-time researchers. While in the West, 300, 400, 500 per million population. That's a big challenge. Africa is still affected by what some people call the evils of the past. We are divided through African languages that are foreign origin. Those who speak French want to work with the French-speaking one, and those who speak English wants to work with English-speaking people, because that's the way resources flow. There's nothing wrong with that, but the resources have that bias, and people align themselves to where they can find the resources. This is also something that is very pertinent in Africa when it comes to epidemics. Most of us can't move freely between our own countries just because we belong to a certain block of countries or, you know, alignment. I was once threatened with arrest in one African country because the immigration officer said I didn't have a transit visa. And there goes my colleague who is Danish working in EDCTP, and they stamp his passport and say he can go, he's free. But we have to question him. Sit down here. So I said, hey, Ula, can you come and negotiate with this man? Because so I was at the mercy of a European colleague to bail me out in an African country. You know, so this is where we are. And then, as if that is not enough, the corruption suspicion index is daunting. All the countries you see there, including mine, are in red. Anybody from South America? Anybody from India or Asian? Thank you very much. So you can see we are not actually the same. Welcome to Africa. We are equally corrupt. That's why you should come to this conference. Thanks, Trudy. So within these challenges and opportunities, I must say that what I've just said to you now are not really challenges. These are what makes our job interesting. And in Africa, we are used to achieving great things by succumbing great adversities. As I said, I come from Malawi. Every tourist who goes to Malawi, they come back and say, why are Malawian people always smiling, but they're living in dire poverty? So we are not poor, we are happy, you know? So that is what we are. So amidst that, when EDCTP was formed some 18 years ago, was the question, how do we link Africans and African research institutions so that they can work together with all these challenges that I've mentioned to you and opportunities? So we did something that was unusual. We put out a call for African institutes to come to South Africa. And when they arrived in the room, we just asked which region they come from. And those who said West Africa, we said, that's your room, you go in there. East Africans go in that room, and West Central Africans go in that room, etc. And then we locked the doors and gave them the agenda. And the agenda was, you discuss what your regional problems are and come up with regional plans on how you can build research capacity in your regions and build trust that has been eroded out of you by the evils of the past. They discussed, they were losers and winners because some people walked out the room and said, I'm not ready to have this discussion. But those that were ready, they wrote very nice proposals. And that was the birth of the regional networks of excellence. This is something that Trudy and I had talked about 18 years ago when we met under a mango tree and say, is this possible that you can force cooperation among Africans? But it did happen. And here we are, we have now 4 regional networks of excellence, and we have gone through a long period of support, which I will not go in much into detail, but between 2008 and 2020, we have had 3 rounds of funding of those networks. We started with 10 million, raised that to 12 million. Why? Because there was a need to include neglected infectious diseases, which were left out. Then they got 18 million and asked to increase their outreach to other countries beyond the original networks. And then the UK gave us money just last year to give to the networks to launch fellowships, PhD fellowships, specifically attracting only female candidates, a very sexist call, but addressing a very important subject of gender disparity in science. And here comes my message to those of you who come from funding agencies or you have friends in funding agencies like Sally. This is a long-term business. And I think the practice of funding networks to have only cycles of 3 years, then you kill it, you start another network, then you fund it for 5 years, then you kill it, is very unscientific. COVID couldn't have taught us enough. I think we need to start thinking about building things for long term and putting in people who can build careers on the issue, not employing people that are already tired like me. I'm not going to add value, but put in young people who should build careers as part of the, a network. And I think this is where the world can benefit from this kind of initiatives. So that's just a picture of what the networks were in phase 1. And then they increased their outreach, as I mentioned. And in this slide, you can see some of the outputs in the last 7 years, which are quite impressive. A lot of workshops, publications that you can find on PubMed Central Europe, and a lot of trainees. But what is also very impressive is the collaborations I've built. The Global Trials Network is a trusted partner in these networks. And other networks that EDCTP has funded, like those of preparedness against epidemics, like Pandora, IDNATE, or ALERT, they are part and parcel of these networks. So what we see is that on top of what is already ongoing, you keep adding layers of networks. And I think this brings another challenge. The challenge is how then you network networks of networks. I think this is where we should be taking the debate, because there's no point having too many networks that are, some of which are not talking to each other and a lot of layers, one on top of the other, but we should be saying, how do we coordinate them? And thanks to WHO for the World Health Assembly Resolution 75.8, which John Reader knows very well, and if you have any questions about that, it's a person you can ask. The member states are asking us to have better coordination mechanism of clinical research in the world, thanks to COVID. And I think when we reach that stage, then we can say we are one and start to comfortably use the buzzword, which I even heard last night at dinner, calling us the ecosystem. Yeah, so we are the ecosystem, pieces of the ecosystem. So I think, let me stop there, because you will hear most interesting and most valuable presentations after me, just to emphasize the importance of sticking around and working in Africa to make a difference. And this is what I think we should all be looking for. Thank you very much.
So thank you very much for that, Tom. Finished with 2 minutes to spare. I think I asked you to stand there because I think you can hear the questions better when you're up there versus sitting. So yeah, open to you guys for any questions for Tom. And I would just say, can you please try to keep your questions short? And if you can, when you get the microphone, if you can sort of walk up closer to the front of the room to ask a question so we can hear up here, that would be very much appreciated. So any questions? So I think we have one over there.
Thank you, Thomas. It was really very interesting talk. Why did EDCTP change its philosophy? Leaving out clinical trials and focusing on other areas of research. I'm just wondering whether the same name could remain if it doesn't deal with clinical trials. Thank you.
Okay, thanks very much for that question. So EDCTP did not leave the clinical trial side and start concentrating on building networks. I was only requested to present the network side of it. But the philosophy of building capacity and networking using hands-on clinical trial work is still the center of the program. I'm sorry if that didn't come out very clearly. Thank you.
Question over there.
Sorry if I missed it, but I didn't hear anything about EDCTP3 and what the plans are. And I just thought the group maybe should know whatever you can say about where we are with that.
Yeah, thanks very much. So that's a good question. EDCTP has indeed gone into EDCTP3, and this is a program that was launched in May in France, who are the president of the European Union currently. And that's another 1.6 billion euro program that is supposed to take us all the way to 2031. If you look at the business plan and the strategic research agenda of EDCTP3, nothing much has really changed except the emphasis of epidemics, reimaging and emerging diseases comes in, and these are the areas that we did not do well in EDCTP1 and EDCTP2. There are other changes in terms of governance and areas of participation. And I think one of the frustrating one that probably you may want me to mention is project leadership, in that most African countries that don't have the science and technology agreement with the EU are not at the moment or cannot be project leaders in the coordination or in the network. And that's just the legality of it. And I think there's a lot of people who are working on it now to make sure that that is well translated, and if there are ways to go around it, we can go around them. But in general, all the African countries that are member of the association, their institutes can still get grants. The leadership is a different thing, which of course to us is an important issue, that an African institute leads a consortium, because it's part of capacity development and knowing how to run consortia that we want to inculcate in our continent. But that's just a technicality. I'm sure it will be sorted out very soon, that we all move forward happily. I hope I answered your question.
Oh. Question back there. Oh. So we'll have the one in the back first and then over here.
Thank you for your presentation. My name is Mercury Shitinda. I wanted to find out, you have mentioned that one of the challenges you're having about networks is them coming to an end or a close. What are some of the things or strategies in place that EDCTP intends on doing, so that we do not have the closure or ending of networks to start others, and building sustainability? Thank you.
No, thanks very much for that question. I think the first thing, as I said, is advocacy and education among funders. I firmly believe that funders have got a lot to learn from the challenges and mistakes they have made in the past. And if they all remain open to that, we can then address your issue. I was saying that because I am also trained in so many networks in the past, and that is not really just comfortable, that you jump from one research network to another following your tutor or mentor. It just doesn't build any capacity that can be long lasting. But hopefully, this is something that we can all sort out at the funders level as some concern that is, generally understood, that we are going backwards if we do so.
So we're co-chairing on my my part because we're already over, but sort of one more question.
Thank you very much. I am Gustavo. I am from Brazil. And I would like to ask you very shortly. So during 2000s, we have a lot of South-South cooperation, especially among African countries. So, but suddenly it's over. How you can see how you can be reconnected in a South-South cooperation to improve equity in Africa and also Latin America in your network?
No, so that's $1 million question. And I think, again, if we come back to the table and open up these questions to different players as our general concerns, I'm sure we can find solutions together. I ask the same question because when we talk about South-South networking only in Africa, that's in a complete picture. We should be talking about, South America, Africa, and Asia as, one network. And I think from the funders side, we should wait to see who is willing among the funders to do this experiment and see how it works, so they can teach others how to do these things better. It's an issue of resources, and as I said in that map, that cannot be underplayed. We come from different delineation of mind, and we are aligned to several different kind of people depending on our background. Those are the things to deal with, even at the funders level, because they are also humans. So for me, the issue of coordination is important. If we have a coordination mechanism, and that coordination mechanism takes up your issue, discuss, and we partner out solutions, and we ask those who have resources to put those resources into it, that would be great. Maybe you should talk to Mr. Bill Gates. Maybe this is an area he would be interested to listen to as well.
Well, thank you. Thank you so much for that, Tom. So we're going to move on now. So right now we have Professor Karen Barnes, who actually hasn't come too far today. She's a clinical pharmacologist based in the University of Cape Town, and she's going to talk about the Worldwide Anti-Malarial Resistant Network. Over to you.
Thank you so much to everyone for this opportunity, and it's lovely to be able to say welcome to my home, and lovely to see so many people here. So today I'm going to tackle the somewhat uncomfortable discussion around data sharing. I think it's something that has incredible potential for public good, but it often makes people feel wary, feel uncomfortable. And I'd like to try and discuss how we collectively can level the playing fields. Next slide. I've got the machine. Yes. So I'm going to look at this from the perspective of the Infectious Diseases Data Observatory that some of you, hopefully most of you might have heard of, which aims to strengthen the generation of evidence through equitable data use. And it's been really successful. It's got over 2,000 research contributors, more than 1 million patient infections. It works on 16 research themes, more on the pipeline. And it's a very international program across Africa, Asia, Europe, and Latin America. I'm going to focus on the Worldwide Anti-Malarial Resistance Network, the malaria part of IDO, mostly because it is the mother of the rest of IDO. And WARN gave birth to all of these new platforms for different neglected, poverty-related infectious diseases. IDO was created because of pressure from research communities saying, you guys are doing great things for malaria, but we need it even more for soil-transmitted helminths or schistosomiasis. And so those communities got together and helped us create platforms for each additional disease. The latest request we've had is to look into scoping TB meningitis, and the doors are always open. This achieves economies of scale and the potential for impact. Also keeps us out of mischief. I think in many ways, WARN can be seen as the pioneer of data sharing. It was started in 2009, a time long before funders and publishers insisted that we have ticked the box that our data is available. So there was no stick to make people want to share their data. We had to find ways to encourage them. And we had to give a lot of thought about how will it work best? How will it achieve the goals of data sharing? How does it achieve that public health good? Groups within WARN and IDO have published really good papers outlining their thoughts. We've debated the issues of ownership. And the most important thing about ownership is when data is shared, you're not giving anything away. You're just sharing it. Other people can use it, but you maintain ownership. You maintain control. There is more and more regulation around compliance. I find it overwhelming how many rules and regulations there are around having someone else's data. The latest is the EU's GDPR requirements. And I sat back initially thinking, no problem, I'm from Africa. I don't have to worry about these EU regulations. But then it turns out if you want any funding from EU, or even if you don't want their funding, you just want to work with someone from the EU, you have to meet their requirements. So to have a platform that does that for you is really great. A lot of our governance has been developed together with TDR. And we're really, really lucky that our data access committee is chaired by TDR. And I think that those interactions over the years helped feed into the WHO's policy and guidelines about data sharing, because we've all built up that experience together over almost 15 years. There are obstacles to data sharing, of course. I think all of us have wondered about, do we want to share our data? Is our data up to public scrutiny from international people that are much better resourced than I am? Can I even find my data? This student has left. I thought it was the final database, but it's got an error. It's not easy. And the longer ago the study was, the harder it is to find the data, and the laptop was stolen. And so it is not easy. And then I think most importantly, people are reluctant because they wonder, well, who will benefit from me going to the trouble of sharing data, the time it will take me to share my data? And there's this sense that someone else out there, bigger, more powerful, will benefit. And it's up to us to be able to benefit if we share data in a way that is equitable. So WARN and IDO have over the many years developed ways to try and address these obstacles. We've developed tools and resources that help people feel more confident of the quality of their data. And for me, it's also way more efficient. I wish someone else had perfected a CRF or a SOP, all the things that I find very tedious, before I started the study, and I could just tweak it for my study. So having other people's tools to help you with each stage of your study improves the quality of your study, but it also expedites research. Data curation is an enormous headache for all of us. And WARN and IDO accept data in whatever format you've got it. If it's an Excel spreadsheet, if it's a very fancy database from a CRO, happy to accept it as it is. And the platform then standardizes the data across wherever people contribute data from and produces data that is compatible. You can download your own data that's now been nicely tidied up by someone else, and you can pull data across all the studies you've done in the last 15 years. And someone else with data access can do the same. So for me, it's a critical point. Curate the data so it's ready for reuse. And we've seen that that increases the frequency with which data sets get reused. So far, we've got some data sets reused up to 15 times. We create study groups, so we get everyone who has relevant data invited to participate in the analysis of the shared data. And then we do individual patient data meta-analyses where you get much greater statistical power because you've got many more patients, you've got increased validity, and importantly, generalizability. We don't need solutions for this little corner of Cape Town. We need solutions for across Africa, for across the world. And we've also been able to identify vulnerable populations that are usually excluded from studies. But when you put all these studies together, you get enough data and you understand what, for instance, malnourished children experience. Lastly, we're part of, like many of you, programs to build capacity. Study groups are a great way of developing capacity. I was so excited to sit at a table with the great minds in my field and hear their insights on how we could set the statistical analysis plan better. We do training workshops, we have postgrad students, we have TDR fellows, and that builds deeper capacity. So this summarizes what I think is the most important part of data sharing, is that once you've expedited data sharing, reuse-ready data, you can synthesize that evidence and answer questions that can't be answered in a single study. For instance, the most recent analysis we did was on the safety of artemisinin combinations in the first trimester of pregnancy. Pregnant women are being treated with quinine, and we know that artemisinin combinations are 6 times more effective, but the WHO was still recommending quinine because they didn't have evidence of safety. So that was a good example. My time's up. Quickly, conclusions. I hope I've persuaded you that equitable, impactful data sharing requires more than just a tick box from funders and publishers and a fair data repository. We need to access the resources that make data sharing and secondary analyses possible. Ensure sustainability, and I like the way Tom says long-term sustainability of these platforms, and give better recognition to researchers for sharing their data. And I think low-income country institutions are particularly bad at valuing that data sharing. Thank you to all.
Thank you, Karen. Next up, we have Dr. Jose Gutierrez, who currently conducts research at the University del Valle in Colombia, and he's going to talk to us about neuroviruses emerging in the Americas network. Over to you, Jose.
Thank you. Thank you very much for everyone to coming and to the Global Health Network for inviting me and my group from Colombia. I have no conflict of interest to be disclosed. I will be talking about our network, the Neuroviruses Emerging in the Americas Network. And our principal interest is acute neuroinflammatory disorders and the healthcare settings in Colombia. So, the network was created in 2016 after the Zika outbreak that happened between 2015 and 2016, and the increase of the Guillain-Barré cases that happened in Colombia and various parts of Latin America. The network is led between the Johns Hopkins University in Baltimore and the University del Valle in Cali, Colombia. It was created as a bidirectional study. We do retrospective and active, which we call prospective inclusion of patients. And initially was a case control study and later a meta cohort study. And its principal objective was to be an observatory of the role of viral infections and acute inflammatory disorders. So, the most important part about the network is the work that we do between all the neurologists, general practitioners, epidemiologists, virologists, and all the multidisciplinary team that works in the network. It extends between 7 cities and 11 hospitals. And the most important part of the network is the training and the coordination and supervision that we do as a team. All the doctors that, all the participants of the network that are trained and in good clinical practices, and we do bi-weekly and monthly meetings to supervise and coordinate and assess problems that we have in a case-by-case basis as a team. The diseases that we our objective are the Guillain-Barré syndrome, encephalitis, myelitis, meningitis, optic neuritis, and cranial nerve palsies. As I told you before, it initially was a case control study from 2016 to 2020 when it became a cohort study. Before the study begins, it needs to be approved by institutional review boards from the university and every healthcare center when it's carried. And they led to the creation of standard operative procedures for fieldwork, and training was done to every general practitioner that is in every hospital, including cases. So we do an inclusion of the cases and we follow up weekly for about 4 weeks. And the patient information is kept online in a platform that is called REDCap. Also, we take biological specimens from every patient and we send them from all of the 7 cities to the laboratory in Cali where they are processed. So the process that we do when we have a case, we have a general practitioner that we call a sentinel that is in active search of patients in the emergency department, the UCIs, and general hospitalization floors. And when we identify a case, it is included, we make a consent and if the patient is under 18 and over 7 years, we also make an assent that he has to be agreed to participate in the study. Then we proceed to take data from the patient. We take demographic data, age, where he lives, in which condition does he live. If he's Colombia, we have a stratum from 1 to 6, that the 1 is the poorest and 6 is the wealthiest. So we take that into account when we include every patient. And we also take account of the general symptoms and neuro symptoms that the patient has taken, the past medical history, and we do a full neuro examination. And we also see the laboratory imaging and electrophysiological studies that the patient took in the hospital. Then with a specimen collection with the blood samples, urine samples, saliva and spinal fluid when available. And from 2020, because of the COVID pandemic, we also take nasopharyngeal and oropharyngeal swabs. Then all the samples are sent to Cali when they are processed for PCR and antibodies studies. And we do a follow-up weekly for 4 weeks when they take neuroexam weekly and blood and urine samples every week also. So in the presentation of the cases, we have a lot of challenges that come from the patient that when the sickness starts and to the final stages of the outpatient follow-up. First is the community. Many patients don't consult because they think that the symptoms are a result of curses, witchcraft, poisoning. So that the patient identifies its symptoms and he consults to the hospital is very important part of the identification of case. Then the patient can go to a hospital of the network or what we call a primary care hospital, where then it's referred to a hospital of the network when they identify the case and include it. And then after the patient is discharged from the hospital, we have to follow him, but it presents a lot of challenges because the patient may live 8 hours from the city or may live in an island. So that is a thing that we're working in with telemedicine to make the follow-up of the patients. So this is what I call the technical achievements that we as a network have accomplished. We have collected the clinical and biological information from 914 patients, a biobank of specimens that blood, saliva, spinal fluid, a bank of MRIs and EMGs that we can use to investigate these diseases. And the most important part, and strengthening of institutional research work. And we are also doing from this year monthly lectures on neuroinflammatory diseases from experts. And it also has led to the creation of rehabilitation app that we call Rehab for Guillain-Barré patients. It's free. It's in Spanish and English if you can, if you want to download it. So as a conclusion, networking with different areas of expertise and different research sites led to the strengthening of the technical capacity of work team and general community. This has led to an improvement in clinical and laboratory training. A lot of our physicians have done international experiences in the Baltimore hospital, and training and application of good clinical practices is our flag here. Oh, my time is up, so I just want to present you the network. The 2 photos on the left are from 2019 when I wasn't part of it. They stopped doing presidential network because of COVID, and just have this photo on the right with 2 other sentinels in a neuro congress that happened this year in Cali. So thank you very much to all, and to all the centers that are part of the network.
Perfect. Thank you so much, Jose. So staying on South America, next up we have Dr. Jacqueline Alga, who's a parasitologist working in the clinical lab at the main public health hospital in Honduras. Today, Dr. Alga is going to talk to us about pregnancy care as an opportunity for a sustainable population-based surveillance system. So over to you, Jacqueline.
Thank you, Sally. Many of you may already know the epidemiologic surveillance systems provide valid, reliable, and timely information. And of course, active surveillance complements routine passive surveillance. However, having an effective active surveillance system presents many challenges. It requires certain level of organization, logistics, and infrastructure, and this means time, cost, and other resources. And also added difficulty when this is in a resource constrained setting, And when there is a pandemic or an epidemic times, also more obstacles. I am going, for that reason, we are promoting prenatal and delivery care because it offers a unique opportunity to collect population-based data. Specifically, delivery care provides these umbilical cord blood samples that through a non-invasive procedure, and also it allows to measure maternal antibodies in cord blood. I am going to share the experience in building research capabilities in Honduras during the Zika epidemic in 2016. As you may recall, the Zika epidemic was a rapid spreading epidemic. It presented difficulties in measuring the exposure. It presented many diagnostic challenges and many unknowns. All of these were obstacles for timely protocol preparation and IRB approval. And also, of course, it required resources. And when the COVID-19 pandemic appeared in 2020, this added an additional degree of difficulties for sustainability. But we were able to assemble a Zika infection in pregnant women in Honduras disease study. As you can see in the graph, we were able to start enrolling participants during the peak of the transmission in Tegucigalpa, the capital city. And we were able to answer our research questions. From July to December 2016, we were able to recruit 667 pregnant women, and we were able to identify 7 pregnancies to provide the prevalence of Zika in pregnant women of 2%. You can see where the pluses are in the graph, and we were also able to identify microcephaly in infants. And in the graph, the 2 cases that are in the square box were 2 children with severe microcephaly. We were also able to assess neurodevelopment, and we assessed 152 normocephalic children, and we are now in the process of analysis, analyzing exposed and non-exposed children to Zika during the pregnancy. Then we are currently enrolling. We are close by October 2022. We are close to 5,000 enrolled pregnant women. We are taking a blood sample at first prenatal visit. That means that we use a very simple approach. And we are now having a follow-up rate at birth of 94%. Then what happened? Why we were able to assemble in a timely manner of this cohort study? Well, because we were already had a 10-year experience during 2005-2016. We had a congenital Chagas disease study. During that study, we were able to build trust, to increasing our capabilities for data collection and sample storage and collection and storage. Then when the Zika epidemic arrived, we were timely able to integrate interdisciplinary, interinstitutional, and international collaboration. We strengthened our diagnostic capabilities, and we did on-site and international training. We put together a manual of standard operative procedures and guidelines, and we did the digital training with REDCap and training on a scale for neurodevelopment assessment. Then what happened with the COVID-19 pandemic? Well, we had to move to a low intensity modality, And we were able to answer some questions during the pandemic, like we used pre-pandemic samples to test the specificity of rapid diagnostic tests in COVID. And we moved from Zika to 0 infection in pregnant women in Honduras. And in regard to some relevant activities or highlights, I can tell you that it was a challenge, but then we obtained IRB approvals, national and international. We also were able to publish the protocol in 2016, and in 2020, we published our main paper with the microcephaly outcomes. We facilitated broad participation in authorship in the papers, including local research team. And also we were able to sustain our cohort because of its potential to provide information on neonatal outcomes and or diagnostic challenge other than Zika, including syphilis. We are analyzing some of these we already implemented, but we are analyzing syphilis, American trypanosomiasis, dengue, chikungunya, and COVID. And in that graph, you can see the different cohorts, including in the Zika individual participant data consortium, and you can see the Honduras cohort stands because it started on the peak of the transmission of Zika. You can see that we had an adequate sample size, and also we were able to maintain it on time. Big recognition to the research team and the research institutions in Honduras and international collaborators. Thank you.
Thank you so much, Jacqueline. So our final talk is from Walter Gingu, who's currently a lab manager in the Nyanza Reproductive Health Society in Kenya. His main research area focuses reproductive health, and today he's going to talk about the capacity of labs as surveillance sites for N-gonorrhea culture and AMR. Over to you, Walter.
Ladies and gentlemen, my name is Walter Agingu, and I'm presenting a paper on capacity of laboratories as surveillance sites for Neisseria gonorrhea diagnosis in Kenya. So it is known that Neisseria gonorrhea infection is of major public health importance because of 3 issues. We have frequency, the whole world, and it causes a lot of morbidity, which some of them have devastating outcomes, and it is treatable. Those are the 3 factors that make it to be important in public health. In Kenya, the infection is treated using syndromic management approach. This is a clinical practice that employs 2 classes of antibiotics administered to symptomatic patients. The practice is threatened by the emergence of multi-drug resistant Neisseria gonorrhea strains that resist both the drugs used for syndromic management. And you know, we don't have any other option. We use syndromic management specifically. A brief history of antimicrobial resistance originates, we can trace it back to around 1930, when the new, antibiotics were discovered for treating Neisseria gonorrhea. And ever since that time, we have had around 4 changes in classes. And this follows the WHO recommendation, where we are expected to change drugs when they show increase in resistance of 5%. So you can see how fast we change. So, so we need intervention to stop community spread of this multi-drug resistant Neisseria gonorrhea strain. We need it because if we don't do anything, very soon we are going to lose over 10 million people annually, and our gross domestic product, the worldwide, can reduce by 3% if we don't do anything by 2050. So we have to look for interventions, and one of the interventions we propose in this study is surveillance. We feel if we do surveillance, proper surveillance, we could overcome. Now, surveillance is where we target asymptomatic people, and then we screen them, then we can take action to break the spread of this disease. Where is it? Okay. The problem we have in Kenya is that we don't have data that show us the capacity of laboratories as surveillance sites. And that's why we are doing the study. It was just to check if we could have some capacity so that we could be able to move forward with surveillance. In this study, cross-sectional data were collected from 12 public hospitals, and we classified those public hospitals into Kenya Essential Package of Health, and we targeted level 4 and above. That's how we classify hospitals in Kenya. Now, our target population was 25 hospitals, but we randomly selected 12, which was accounting to 48%. We were looking at the hospitals with STI services and with labs that could offer basic microbiology, and those ones with data management system. So in the labs, we looked for availability of basic equipment and consumables that were able to enable us, diagnose Neisseria gonorrhea. I don't know whether the results are visible, but in the results, we found that 50% of the facilities had less than 6 essential equipment for diagnosing gonorrhea, and 91.7% of the facilities lacked basic equipment like biological wire loop for scientists who are here, you understand, and magnetic stirrer. We also categorized the hospitals into urban and rural, and we realized that urban hospitals had only 36.4% of the essential equipment compared to rural hospitals at 18.2%. So when we looked at the consumables, we found that all the study sites lacked 56.3% of the essential consumables. And you can see the consumables here. Those ones were the essential consumables we were assessing. And then when we went to capacity, we realized over 91.7% of the study sites lacked capacity to perform Neisseria gonorrhea culture and susceptibility testing. So in the discussion, we realized that all the 12 facilities reported having qualified laboratory staff, so qualification was not a problem. But also we realized that only level 5 hospital, the only one in the county, had some capacity to perform culture and antimicrobial susceptibility testing, which we usually call phenotyping. But they could not do antimicrobial resistance testing called genotyping because they lacked some facilities. Also, the only hospital had that capacity, but it could only do other microorganisms, other bacteria. It could culture for other bacteria other than Neisseria gonorrhea. So even that hospital could not culture for Neisseria gonorrhea. So this study concludes that the results can enable the government to identify the hospital they can enhance to act as surveillance sites in Kenya. Then we had some few recommendations. One, this lab staff should still undergo mandatory and regular continuous professional development, especially in the field of surveillance. And we also thought that at least one level 5 hospital per county should be enhanced to act as sentinel surveillance site for Neisseria gonorrhea and other organisms. And then level 4s, some of them should be identified and be act as satellite sites where we could collect samples. And then we suggest that ongoing surveillance is required to reveal community transmission patterns of multi-drug resistant strains. Then I would like to acknowledge the sponsors, specifically the Global Health Network. Then I'm going to also acknowledge my supervisors. This is part of my one of the specific objectives for my PhD, which is almost going through. I'm thanking managers and staff of the various hospitals, the universities, and then Nyanza Reproductive Health Society, where I work for. And all of you, thank you. These are my references.
So thank you so much for that, Walter. So I think you can probably all agree with me that the variety of talks we've seen today have certainly lived up to the title of research in every healthcare setting. I think we've seen the creation of networks to assist with data sharing in malaria and to catalyze lab collaborations on neuroinflammatory disorders. We've seen a focus on surveillance, the opportunity presented by pregnancy to capture data over time, and the need for robust AMR surveillance to guide appropriate antibiotic treatment. For me, in particular, it was really great to see that all the presentations today showed research driven by in-country needs, the outputs of which are directly relevant to the countries themselves. I think this is so important when we think about sustainability of funding, of capability, and also of adoption of outputs into practice. For me, I think there were sort of a few sort of key takeaways. And at the end, I will give you guys all a chance to sort of say what your key takeaways were from your presentations. But the three key takeaways for me were, one, that networks come in all shapes and sizes. But regardless of the size, there's obviously, the whole is greater than the sum of the parts, and there's a unique value in working within the context of a network, which I think I'm probably preaching to the choir, seeing as the title of the conference is the Global Health Network. The second point, I think, is really about taking advantage of frameworks that already exist. So for example, leveraging existing ongoing touch points with healthcare professionals as part of a surveillance system. And the third really was, there's clearly a role in utilizing research to understand the gaps that might exist in country and the importance of capability building, but in a sustainable way, whether it's looking at things like tools for data collection or for AMR. So with that, hopefully I did a just summary of what you guys presented. And I'll hand over to the audience for any questions you might have. And just to sort of remind everyone to please keep your questions short. Thank you. So I think we have a question over there. We're here first and then to the back.
Thanks very much. My name's Emma Kolk. I'm in the School of Public Health at the University of Cape Town. I want to address my question to the data sharing and just to ask how you reconcile a commitment to the principles of open data and data sharing with the need to respect confidentiality and to comply with the various legal and ethical infrastructures. And this refers specifically to routine operational data, which was mentioned a bit earlier, where participants haven't consented directly to the use of their data and certainly haven't consented to sharing their data across borders. Thanks.
Thanks, Emma. Great question. And of course, a big topic. I think that within the Infectious Diseases Data Observatory, all data is fully anonymized and it is shared with the data contributor being responsible for making sure that they're not sharing data that would not comply with existing rules and regulations. And the anonymity is obviously a really important part. Within our tools and resources, we help people with things like, as does TGHN, consent forms that allows for future use of relevant data. I'm very interested at the moment in dealing with artemisinin resistance in Africa and wanting, and it's really interesting to hear about strengthening surveillance data. And of course, that becomes more complex when people get dry blood spots, which we can use to track surveillance. And I think it depends very much then whether it's under the mandate of the Ministry of Health, the National Malaria Program that needs that data rather than a research question. And I think that changes the nature of the consent. Great question, Emma. Thank you.
So, yeah, question right here.
Thank you. My question is also to Professor Karen Barnes. And, thank you for excellent presentation. I was just wondering how you reconcile with validity and precision issues. When you are bringing so many data together, you are increasing your precision, you're increasing your statistical power, you can do meta-analysis. But what about validity, So could it be like that if the quality is not maintained properly, then we'll have very highly precise but invalid inferences coming from there. So what sort of guarding mechanism you do imply for that? Thank you.
Thank you. Another great question. It's a really important consideration when you pool available data. And there are numerous statistical techniques that get used to make sure that we haven't got one study that's an outlier, an influential study. So we do things like adjust for clustering that would occur, not just by study, but also by study site, particularly for patient reported outcomes. How we ask those questions change the answers. So you do see variation. And so it's largely through the techniques used. I also find it really, really powerful to include data contributors in study groups because they have the insights, and when their data seems to be slightly different, they have the position there to say, well, this is what's unusual about our community. It's not that the data is invalid, but there's lots of illicit drug sales of very poor quality drugs or something that would explain that. So I think there are numerous steps you have to take. But we see the value of individual patient data over aggregated data that a lot of other groups compare because we're able to identify the subpopulations that probably have the highest burden of a given disease, but are often underrepresented in studies. And so by being able to look at them individually, even if the aggregated data didn't do subset analyses, we find helpful. Thank you. We can talk more at tea.
I think there was a question back there. Yeah, back there.
Thank you very much. My name is Robert from Ghana. And I must say those are very interesting presentations. Apologies if my question is also directed to the presenter on data sharing, because I thought that was quite thought-provoking. My question to you is, how do we unbridle this whole issue of power play between funders and then research scientists? Because oftentimes the funder comes with the agenda already set, and then you, the researcher, more or less, you don't have a bigger muscle. So you are collecting the data on the field and it's already landing somewhere in a server. Where is the sharing protocol? What would be your, suggestions and maybe some few recommendations, particularly for those of us who are early and then mid-career researchers? Thank you very much.
Great question. I hope the next question is for someone else. I think that it's really, really important. And I think that's why I put so much emphasis on a repository that curates data and it's ready to reuse. In the start of our work, it would often take 1 or 2 years to collate and curate all the data in a way where we could do a secondary analysis. But once that's done, all we want is for someone like you to come and say, in Ghana, we're really worried about artesunate amodiaquin doing something strange to safety. And we have this question. I've spoken to my friends in West and East Africa. They have the same question. I want to see if there's enough data out there that can answer my question. So it's up to us as a community to pose questions, TDR has a data access committee. They'll say this is very credible use of that data. It's compliant with what we meant to be doing. And the nice thing about once the data is in the repository, there's no funder in control of the agenda of what the data gets used for. And the more it gets used, the more questions we answer, the better off we all are. Thank you.
Just quickly to add to that, as a funder, I feel like funders are getting a bad rap here today. And just to say that, I guess we do have our sort of strategies and agendas to a certain extent, but I would like to think that increasingly we are sort of open and are listening to what countries want and what countries need. Because what we want as funders is to make impact, right? And you guys know better than we do what's needed to make impact. So yeah, hopefully that's sort of coming across a lot more in the interactions and discussions that we have with you guys. So on to the next questions. Hopefully Karen is going to get a bit of a break.
I do have one question here. So I'm sorry, this is also regarding data sharing. I had plenty of questions for the data resharing part, but let me just move to the most important one, which is you mentioned the data being anonymized completely. So my question is like, if the data is truly anonymized as per GDPR, what can you comment on the usefulness of the data and what covariates are lost and how can people use that data once it's truly anonymized?
Sorry, we didn't hear the question properly. Do you mind coming closer to the front?
Yeah, so my question was about data anonymization. So the question is like, if the data is truly anonymized as per GDPR, which is a very vague definition, but then, people cut out certain covariates, you take the end of the tail and so on. So my question is like, how useful is the data once it's completely anonymized as per GDPR for secondary analysis, pooling, IPD between studies? Thank you.
Thank you so much for that question, because it reminds me what I didn't say and what I should have said is the most important aspect of a data repository like ours is that the data is linked. So we can see that this person who had a treatment failure had these mutations in their parasites and had a normal drug concentration. So it wasn't underdosing or unusual pharmacokinetics. By linking all of those things, that's when the data is useful. And we do the same thing. We see that some adverse events are more common in young children. We can see higher treatment failure in people who are wasted, but not in children who are stunted. So I should have emphasized these guys at the front with minutes looking at you make you rush. I should have emphasized the importance of the linked data.
Right. So time for 2 more questions, I think. So in front and then back. Okay, 3 more questions.
Thanks to everyone. My name is Yoba Seidu. I work for the Clinton Health Access Initiative. Unfortunately, my question is not about data sharing, so I think yeah, you can relax. My question is actually directed to Thomas. Thanks for the exciting and insightful presentation. I think EDCTP has kind of accomplished a lot based on what you have said, and perhaps one of the key things that led to this great achievement is the involvement of researchers and PIs from Africa taking the lead. But you kind of mentioned something that is very disturbing, indicating that there are some sort of legal concerns that particularly countries that do not have science and technology agreement with the EU cannot lead those in short projects funded by the EU. So I think for me, it's a little bit concerning because that can affect motivation and so on. And the question is, what can we do as researchers, as as maybe advocates to actually facilitate this sort of legal agreement? I know I have done research, and I know researchers are really not very good at getting governments sign legal agreements. But I know other people like development partners are very good at that time, at actually getting government to enter into agreements. We have seen that with Global Fund, United, and maybe Gavi, at least getting governments to enter into agreement, pay co-financing, and subsequently sustain the investment. So is there anything we can learn? Can we take that angle to actually get our governments to enter into those agreements, facilitate? Can we leverage the know-how of development partners to get this thing in place? Because it's a very important aspect. Over.
No, thanks very much. I think that's a very difficult question to answer in 1 minute. So I think we can take that offline, so to see what you can do to help your country to overcome those hurdles. I really understand that getting science and technology agreement between states and unions is not a one-day thing. And I'm sure most countries that don't have the agreement have pondered over it before and weighed the advantages and disadvantages and took their priorities. And yeah, but we are on the receiving end. And I think this can be done, can be solved in different ways. But advocacy, like what you're doing now, is also very important, because if it goes into the reports of the conference, that conference participants were concerned with such kind of arrangement, then it starts to make, some people start to hear. Yeah, but we can take it offline and then we can work together on that.
Really sorry, but we don't have time for any more questions. But feel free to catch any of the panel members during the break we have next. But I'm going to ask you guys, and really quickly, because otherwise Trudy's never going to invite me to chair ever again. So 20 seconds, what's the sort of one key takeaway you'd want the audience to take from what you presented today?
Yeah, so for me, I think it's quite clear that networks and collaborations are a way to go. And but we also need to look at the local context, the ownership and leadership of the sites and the countries is also very important, because just copying and pasting is not a wise idea.
I've probably already said more than enough, but I want to emphasize the power of us working together. Wherever we choose to network as much as possible in the places that benefit the communities the most, and for funders to keep making that possible. Thank you.
I think the network is the most important part of every research setting, and we all can learn from each other, and that we can solve particular problems as a team is the most important part.
I would like to say that building trust is a multi ways, because we had to build trust across departments within one hospital, and then across institutions in Honduras, and then 2 ways from Honduras to the international collaborators and from them to us.
Okay, my take-home message is that we need one health approach, and we have to unite as a world to fight antimicrobial resistance. Otherwise, we are going to perish very soon. So let's unite, fight the way we fought HIV, the way we fought COVID. Another problem is antimicrobial resistance. Veterinarians, health, medical people, farmers, everybody please rise up, spread the gospel.
Yeah, I think all that's left for me is to say thank you very much to the panel.
Thank you.
Thank you. Thank you, Sally. Thank you, panel. That's really excellent. So, do you know, one of the nicest things that turned out by chance is the nice little bit of exercise we get, a little bit of sunshine, bit of vitamin D. So I'm going to say ready, steady, go again. And then back here, absolutely to start on time, because we've got a really great session to finish the day. And then don't forget, we're going to have the group photograph, which is critical. I mean, what a fantastic, we can't miss that, can we, at the end of the last session on the steps. So enjoy the cakes and tea and coffee, but jog to earn it. And then absolutely, we're going to start bang on time with the session we've got after tea. So sitting down at 4. Thank you very much. And thank you again, panel.
te fait du mal, s'il te plaît, n'y pense plus. Il a souillé ton âme, toi tu t'es battu. Ton cœur est plus précieux que de l'or. Ne pense plus à lui. Pour un homme, tu ne veux plus voir le jour. Des milliers d'entre eux rêvent de te faire l'amour. Ton corps est aussi beau que l'or, que l'aurore. Encore tu pleures pour une histoire de love. Ils vont encore dire que t'as qu'ils ne parlent que d'amour ou d'amour. Mais c'est toi qui demandes à être consolé. Moi je suis ton ami et les amis font ça toujours. Donc on va parler. Tu t'es plié en quatre pour un salaud. Et pour vous tu t'es donné sans compter. Lui il a planté le couteau et il a regardé ton sang couler. Et depuis tu ne sors plus. J'ai demandé, on m'a dit tu ne manges plus. Yeah. Mon avis tu voulais. Oh, ne pense plus à lui. Fais du mal, s'il te plaît, n'y pense plus. Il a souillé ton âme, toi tu t'es battu. Ton cœur est plus précieux que de l'or. Ne pense plus à lui. Pour un homme, tu ne veux plus voir le jour. Des milliers d'entre eux rêvent de te faire l'amour. Ton corps est aussi beau que l'or. Que l'or. Pour un petit fils de yeah. Je n'aurais jamais pensé qu'une femme comme toi puisse tomber aussi bas. Tu l'aimais, lui il t'a fait payer. Aujourd'hui tu le maudis. Moi c'est toi que je maudis et tu vas comprendre pourquoi. Personne ne t'a forcé à rester. Non, non, personne ne t'a forcé à rester. Tu étais tellement fier de vous, fier de vous. Aucun homme ne pourra te faire tomber. Non, non, aucun homme ne pourra te faire tomber. T'es la fille de ta mère, le bijou de ton père.
Welcome to the last session of the first day of this conference. But this is a very important session. As you know, I mean, all these people who are sitting here, they would be telling us something their experience about community engaged research that they have done in their part of the world. And therefore, for this theme of this conference, the engaging community in all the, the cycle of the research process is such a vital issue in present scenario of research practices all over the world, especially in the developing countries, I should say. So it is my privilege and honor to chair this session with such distinguished speakers, and I'll just call their names so that you can understand who they are. So Gustavo Mata, Gloria Beni, Edward Kaingo, Cressida Bauer, Gertrude Banda, Bartholomew Wilson, Angela Carlo. So they are from Brazil, India, Kenya, Malawi, Liberia, you name it. So you have such a great mix of speakers with us. And for community engagement and involvement, you know that the concept had very importance from the days of Alma Ata Declaration and the 5 principles of primary healthcare. One of that was community participation. And sustainable development goal also, we have this community participation. So not only for the health development, but for the research also, how the people and the patient can have the central place in a very engaged community, which addresses the equity concern. So these are the things I think our speakers will be deliberating upon in their presentations. And I hope you agree with me that the clinical trials have got a disproportionately more important part in health research. There are many different methodologies which complement the clinical trial. The clinical trials are only the end point of this whole ecosystem of research. So therefore, I think here we are to have a more balanced approach of a very comprehensive, holistic view of the process of research. And therefore, without further ado, I would first invite Dr. Gustavo Mata, who is a very distinguished public health researcher from Fiocruz in Brazil, and who will share his experience in community engagement in JICA, where is this thing in Brazil. So floor is yours. Thank you.
Yes, thank you. Thank you very much. It's a privilege to be here. So I would like to thank for MESH and the Global Health for inviting me to come. I am a bit nervous because, you know, Brazil will play today in the World Cup. That's why I'm a bit nervous. It will be our first match. And after Germany and Argentina lost, so I don't know. So, and well, just to break the ice. So, and I will tell you more about our experience during Zika outbreak, and it is so important because it was the first day that I met the Global Health Network. We worked together through the NDI during the Zika Alliance Consortium, so funded by European Commission. And after it, we will also have many and important national and international connections, right, to support Zika outbreak in Brazil. So just to contextualize a little bit what I am from, right? So talking about public health in Brazil, it's not very usual. We used to talk about collective health. It's something that started in our Latin American movement of social medicine, right? It's in the same time when we are fighting against dictatorship. So talking about collective health is also talking about interdisciplinary perspective, right? We try to interconnect three important dimensions of these rich fields. So epidemiology, policy and planning, and also social science and humanities. And also to be based on it, so democracy, it's an important and crucial issue that we will have to build on, right? So, and the second point is during our reform movement on public health, during 1988, we put in our constitution the right for health, right? So our national health system is a universal health system. That's why sometimes we discuss with a global health perspective of universal health coverage. Not necessary, so because it's something universal, it's a kind of a health. All right. So there are three main principles of our national health system. So universal right to health, decentralization in three levels, federal, state, and municipalities, and social participation. We cannot do anything with consulting society, right? We have councils in municipalities, state, and also in the federal government. In this moment, we are having the most important Congress in Salvador, the Collective Health Congress, right? And we are very happy because now we are having hope again about our country, right? We will start to be reconnected, not just only in Brazil, but in the whole world. So I hope we will have very good connections in the future. So
About Zika. So in the last session, we have a colleague from Honduras that we already talked a little bit about Zika. But Zika is important to say. Represented, it still is an uncertain issue in public health. Science, health, and society are intrinsically entangled in the Zika outbreak and its repercussions. Global, regional, and local inequalities characterize the Zika epidemic and responses. So Zika as a political and social analysis of the invisibility of multi-disabled children and people in around the world. Controlling the mosquitoes itself as a biological identity without historical and gender entanglements. That's what we have in the global health scenario. So every health emergency for us, and I think that most of us, is a humanitarian crisis. So this is important just to show that Zika came in the northeast of Brazil. The northeast of Brazil is the most unequal region in our country. And then, if you can see here, entering Pernambuco in 2015, and then in 2016. You can see in the gray area, this is the most endemic area for dengue, right? When we have a lot of Aedes aegypti. So this is the main pictures that you probably remember during Zika outbreak, right? So about children with microcephaly. So, but Zika, it's not just it, it's just one of the signals. There is an important damage in the brain. It's a kind of syndrome. Most of them don't have microcephaly. It's important to say, right? So immediately after birth, we cannot identify the Zika immediately. And then during the years, we can have identification of lack of development, right? And the other picture is the mosquitoes, right? And then we start a kind of a war against mosquitoes. So we receive a lot of investments to improve biotechnological initiatives to control mosquitoes, right? Everywhere. Again, when we talk about health emergency, the metaphor of war, it's always present. Probably we will have to reimagine this kind of a metaphor. So soldiers, we ask the army to go to the houses, to have clean water and everything. But we don't talk about inequalities. We don't talk about lack of segmentation. We don't talk about pregnant women in poor areas, in vulnerable populations. So one important communication piece from Minister of Health after 2016, after the impeachment of Dilma Rousseff, that we usually call a coup. So it was this: a mosquito cannot be stronger than a country. So this is very important because this is our trajectory, right? Since the 80s, we can't control dengue. We have cycles of dengue epidemic in our country and coming over again. So now we are having a new dengue epidemic. And so there's no necessary global health attention about this. Well, we publish many papers. I think that this is not important, most important deliverable about our work, but we highlight some global health uncertainties, public health uncertainties, social and political uncertainties. So we had 2 presidents during Zika outbreak, 4 ministers of health. And we also were in a very important economic and political crisis. It was our contest, right? How can I talk with public health emergency without context, right? I am a social scientist, so context contests, and contests. This is the most important thing for us. So the whole of Zika outbreak entangled gender, race, and social structural inequalities. So I would like just to highlight some points here. So in one of them, so the whole of women in Zika scientific leadership and social activism. The most of leaders in science and also social movements during Zika outbreak were and still are women. So this is important in a more strong way when we would like to improve gender equity in science field. So the community-led responses, it was a kind of a rapid organization of mothers in a WhatsApp group. I think that it's not possible if we remember HIV/AIDS epidemic. There's no WhatsApp in that moment. And they share pictures, they share newspapers, they share pictures about their kids, so how they are developing or not. So it was very important in this kind of a communication, and this is also an important tools of community engagement initiatives. So the participation in many situations room in municipalities, states, and also in federal governments, because social participation is one of our principles. It's impossible to make policies without the participation of society. And it's not just about Fiocruz, but everything that Fiocruz did in that moment, we involved representation of the mothers, the most affected people by Zika, right? So we also have important meeting. I think that it is one of the most important deliverables that we had, right? When we discuss with scientists, policymakers, and social movements what we learn about Zika. It was in 2018. There's many meetings before this. So, and then we wrote a document with recommendations to federal government, state, and also municipalities. So the recommendations, it's unfortunately, I don't have many time to detail, but also involved child care, caring for women, public policies, health communication, social participation, health surveillance, prevention, control, science, technology, information, and ethics. So this is, for me, the second most important deliverable of our work. We create a Zika exhibition with the participation also of society. And the mothers' movements are using this, yes, to discuss their needs, to expose their needs and their challenges as well. So I am running a little bit. So, and we also create a website about Zika Social Science Network in the Global Health Network website. So we have, I think, a kind of an editorial work, right? So we had a collaborative paper with social movements published in British Medical Journal, right? When we describe our experience during Zika and what are the main challenges to improve scientific cooperation, national and international, right? Highlighting many issues and challenges. So the post-Zika repercussions, Zika became completely invisible since 2018, especially after the end of WHO international public health emergency. The post-epidemic social and community consequences are usually missed by health and political authorities, as well funders. There's no funding anymore for Zika research, right? Mothers Association are still fighting against acting to support and seek health assistance to social protection. And in 2020, the Brazilian parliament, based on our documents, instituted a law to guarantee a fellowship to the mothers affected by Zika. So the conclusions. So children affected by Zika have been framed and treated in our country. So, but neglected population groups are still inscribing further inequalities in Brazil and also in the global health genealogy. COVID-19 difficulted a lot the health access and social protection among families. So they have many difficulties on that. So I already said this, and gender issues in scientific production and social protection still are invisible to governments and also funders. So for me, and it will be my last words, I promise. So the power imbalance between funders, scientific health professional, and last, but always least, communities. Inequalities, democratic settings that we have to face, because democracy, it's nothing already done. Representative democracy is not enough. How we can democratize our everyday life in different communities, right? Community engagement as a way to legitimate the scientific truth. Communities have to learn and scientists have to teach. This is something very usual in our, I'm sorry, I stopped, but okay, I'm finalizing. So epistemicide of knowledge, practice, and culture in the global south. The scientific ethos is more competitive than a collaborative field. So I was to say that it's a kind of arena. And which science we want communities to be engaged. And then I would like to invite you thinking on 3 principles that I would like to share with you. So the political epistemological perspective on community engagement to create a new ontology, democracy, a decolonial approach, and health and social justice. That's it. Thank you very much.
So I invite next speaker. So what we're trying to do is that we'll keep the questions at the end of the, all the speakers when they speak, then we'll keep some time for the question and answer session. So please, let's hear from you. So Edward Kayenga, is that? Gloria. Okay, Gloria Benny. Yeah. Okay, please.
Hello, everyone. So I am Gloria Benny, working at George Institute for Global Health, India. I, on behalf of my colleagues, would like to present some of the findings of a qualitative study with the Kartanaikan community, which is actually a tribal community from Wayanad, is a district in Kerala, a South Indian state. We are looking at the role of tribal people's participation on a government-led community health worker program. So to give a context to the study, community health workers are actually key in bridging the gap between the health systems and the people, which is the community members themselves. And the tribal community health worker program here in the study area, which is in Kerala, it was a new program that was launched in 2016, which is called Urmitram in the local language. And the community health workers in the Urmitram program was named as Ur Asha, which means Ur means the tribal hamlet or the settlements, and Asha is the name coined for community health workers under the program by National Health Mission in India. So tribal communities within the area that they are getting the services are actually the direct beneficiaries of the services provided by these Ur Ashas, but they are also having a specific role in the selection of these community health workers, which is the Ur Asha, and they also have to support to complete the task given to Ur Ashas. So the research objective is to understand how community participation was envisaged and manifested in the Urmitram program. So as you see in the slide, the study was a qualitative descriptive analysis, which was part of a larger tribal health implementation research study. And for the larger study, we employed a purposive criterion sampling, while for this sub-analysis, we employed theoretical sampling. And we conducted data collection, which we used key informant interviews and in-depth interviews and group interviews among 18 females and 14 males. And our participant profile was tribal community workers, community leaders, community-based organization actors, healthcare providers, some scholars, as well as the community members. And among the community members is what we were doing the group interviews. We actually secured permissions from the different department heads, mainly health, forest, some of the tribal departments. And then we have some of the local self-government institutions there, which is kind of a grassroots level gatekeepers. So we got permission from them as well. And with that, we went on for the data collection. We secured individual written informed consent or audio recorded informed consent from the participants. For the analysis, we used a thematic analysis, and we did it using Atlas TI-8 software. So we have some of the illustrative findings that we'll be showing up here. And our participants, when we were inquiring them about the role of URASHA, which they kind of understand and the program has envisaged, one of the group interview community members said it is very important that all households should collectively cooperate with URASHA. URASHAs should look after pregnant cases and children. She should do the necessary arrangements to bring them to the hospital during emergencies, and also should help us to get financial assistance. It will definitely help us to improve our health. Now, regarding the selection of URASHAs, here we have a response from one of the key informant who is also a public health staff. She said the way how they do selection of URASHA is basically the community members will select 2 persons through the Urukutam meeting. Urukutam is basically a monthly meeting that is held within the tribal hamlets with all the community members and the community leader within the hamlet itself. So they have to propose 2 people, and then this list has to be passed up to the department, and they will be selecting the 2 persons, one among the 2 persons. And along with this, there comes actually some challenges in community participation, which was told by one of the community members through our group interviews. So this person is saying that the community members, who is actually their fellow members, won't come for sure for these kind of meetings when they call for, which they kind of think that there is no sense of collectiveness among the community members. If we say anything or do anything, we think that it would be beneficial for everyone, and all the community members should stand with us without any second thought. But they would never do that. If a meeting was called for discussing such important things, only half of the people will go for it. So that was kind of a challenge the community themselves were raising regarding the community participation. And regarding the role of community, one of the key informants who is actually a scholar in the tribal area was saying that even an ASHA, who is the community health worker, has to act as a catalyst only. She must only be a person who is involved in the service delivery system. The involvement, leadership, and decision-making must come from within the community itself. It is not there in our state, which they kind of point out to the gap that is existing in the state. And so summing up what I was projecting over here, community participation envisaged in the Urimitram program happened diverse across project areas. While some community participation was actively, which was as envisioned in the project, in some places, some CHW selections was based on the prior engagement with the health system. So there were some of the cases where, the people who have existing informal relationship with the health system or some acquaintances with them were also selected, were approached by the health staff. And varying community priorities resulted in this mismatch between what was envisaged and what was actually intended in the role of the community in terms of the community participation. And then we propose a policy formulation on mandating a tailored community participation strategy, which is required in designing and implementing any new programs. So the study was actually a smaller study, so as such, we had some limitations to that. The questionnaire was actually tailored and it was framed according to the larger study. And so the focus for the selection of CHWs and community's role in it was not a priority probe in it. So we had so limited responses from the participants due to the same reason. And this project actually happened just before the COVID happened and as soon as when the pandemic was there. So partially our data collection was telephonically done. And this, we feel like if we were doing it as in-person, face-to-face interviews, we could have got more nuanced community participation understandings from the community. So this we consider as a limitation to our study. And yes, so we would like to acknowledge the participants of the study who have given their time and valuable inputs, also to the funding agency, Indian Council for Medical Research. Thank you.
Thank you, Gloria. Finishing it before time, a few seconds before. And I'm sure you people must be knowing that the Kerala state of India is one of the exemplar achievement in health in a state, which was, like, say, more than 4 decades ago, good health, low cost, so Kerala was that. And now they have come with the tribal community health worker. So it is a beautiful idea, which they have implemented. So for the next speaker, I would want to invite Edward Kayongo, and he would be talking about pictorial evidence profiles for involvement of less empowered citizens in high-level decision making.
Good evening, everyone. So my name is Kayongo Edward. I come from the Center for Rapid Evidence Synthesis, based at Makerere University, the College of Health Sciences. So I'm here to basically talk about pictorial evidence profiles for the involvement of the less empowered citizens in high-level decision making. So basically, we come from the point of view that many policies are actually set and implemented in countries without necessarily involving the less empowered. And in this case, we are calling the less empowered the people who typically are left out of decision-making processes, like people who can't probably read or write, people who are less fortunate, they have less than others in society, they haven't gotten university degrees. Those are the people we are looking out for and trying to get their input into the decision-making process. So a bit of a background to this is that there are several efforts that have been undertaken globally to get citizen voices into the decision-making processes. Some of these are like citizen panels. In Uganda, we have what we call the barazas, where the government goes out deliberately to the society and seeks out voices input into the decision-making processes. But challenges still do exist in this process. We have politicians not trusting the citizens to be able to engage within the policy-making process, but also there is this general belief that citizens do not have the capacity to actually engage within the decision or policy-making process. So we tried to bridge that gap through using the pictorial evidence for decision-making. So here we piloted the pictorial evidence profile for engagement of the less empowered citizens through evidence-informed citizen panels. And I'm going to talk about 3 case studies. The initial case study was about COVID-19 vaccine hesitancy in the country. So at the beginning of the COVID pandemic, we all know there were no vaccines, but then the process of vaccine development was really fast. Even people within the scientific world feared getting the vaccine. So you can imagine the person down there in the village, what they would think about getting this vaccine. So we had very high rates of hesitancy towards COVID-19 vaccine in the country. And when we are supporting government to roll out the vaccines in the country, the question came up about how can we address vaccine hesitancy. It was a little bit easier to engage people who can read and write, people who own televisions and radios, where they could watch government programs, read Twitter messages, Facebook messages, and the like. But imagine a person down there who doesn't own a smartphone, a person who rarely watches TV. How is government going to get to them? And in case they go to them, how are they going to get their input into addressing COVID-19 vaccine hesitancy? So that is the project we started with. So basically speaking, we first generated an evidence brief about COVID-19 vaccine hesitancy, the causes and the possible solutions addressing the challenge. That could resonate properly with people who can read and write, people who are really empowered. But then the people who cannot read and write, people who work in marketplaces, people who work on the streets, they don't really get the opportunity to interact with such kind of evidence. So we sat down internal as an office, discussed how we can change this evidence into pictorials, came up with the first working drafts of these pictorials, had an internal review, made a few changes. Then we did user testing among the target population we are aiming for, made more changes, and then used the final evidence briefs in pictorial form in 2 citizen panels. So that was the very first attempt, and these were the results. So on your left, that is where we started from, and the pictures on the top of the screen are talking about causes of COVID-19 vaccine hesitancy. So one of the key points in Uganda was the country from which the vaccine has been manufactured. So there was a lot of buzz around people getting vaccines manufactured in the UK versus India and China. And then later on, Johnson & Johnson came on board from the US. So you have people preferring to get UK and US versus China, India. The vaccine that was made in Russia was also available in the country, people refusing to get those kind of vaccines. So then vaccines being perceived as donations was also another issue that came up. Healthcare workers not wanting to get the vaccine, lack of access to information, and then trying to ask, the question mark stands for asking the citizens about what more do you think are the reasons as to why you're not getting the vaccine. So on your right is the alternation after user testing. So people told us when they look at the globe, several things can come to their minds. But if you add the globe and the picture of a factory, then you could possibly think about country of manufacture or region where the vaccine has been manufactured from. We also changed the box of a gift to include some few vials in it to show that it is drugs. Then the information we change from the other file to someone who is teaching or someone talking about something like in a class kind of setting or a lecture kind of setting. The same alterations happened with the picture, the 2 pictures at the bottom, which are talking about measures of how we can address vaccine hesitancy. So then our next attempt at this was when we were working on 2 more questions that are not really part of COVID-19. One of the questions was looking at male involvement in the control of teenage pregnancies. And then the second question was looking at how we can achieve exclusive breastfeeding in the informal sector, people who work within the informal sector. So what we did in this particular alteration this time round, we didn't do anything internally in terms of coming up with illustrations. We actually had to engage people within the publishing industry to help us conceptualize the messages we have in text format and convert them into pictures so that we can use these pictures for dissemination and engaging the citizens who can't read or write. So the first illustrations here are the ones on male involvement, where we have things like using messages on smartphones, getting the young men busy so that their minds are really off relationships with the teenage girls, creating teenage kind of clinics, getting parents involved in talking to their teenage boys about sexual and reproductive health and things like that. The second one is about exclusive breastfeeding. We are trying to come up with interventions on how we could actually encourage exclusivity in breastfeeding in the informal sector. So those are the illustrations we came up with. They still went through the different alternations. So we would get the text submitted to the people within the publishing industry. They would come up with the initial drafts of the illustrations they think would pass on this message. We would go through internal review, then do user testing with the external reviewers, the people, the target population for this kind of information. Then we would come up with the final illustrations to use. Then we'd get these illustrations and use them to engage citizens in an evidence-informed discussion that would eventually feed into the policy making process. So from this, what we realized is that these individuals who are usually left out in the decision-making process, I'm about to stop. These individuals who are actually left out in the decision-making process actually have rich information, contextual information that can feed into the policy and decision-making process. We have to deliberately seek this information out from them by engaging them within these processes. However, challenges still do exist. A picture can only say so much. So there's still a bit of challenge here and there whereby you have to talk for the picture sometimes, where the picture cannot really do all that talking on its own. Thank you very much. That is it.
Thank you very much, Mr. Kango. Pictorial evidence, very innovative indeed. Now I invite Cressida Bowyer from Kenya to present her paper.
Hi, everyone. I'm Cressida from the University of Portsmouth in the UK, and it's excellent to be here. Where's the and I'd like to talk to you about a community-led sensitization campaign for a project called Tupamui that took place in Nairobi in Kenya. Okay. Can you stop the clock? There we go. So Tupamui was really the first of its kind research study to compare the lung health of children attending school in informal settlements compared to children attending school in a planned settlement. And you can see in the top picture, that's the informal settlement of Mukuru in Nairobi. And the bottom picture is the planned settlement called Buruburu. And informal settlement dwellers face many inequalities, of which air pollution is just one. So we started off with an extensive community consultation and stakeholder engagement process. And we carried out 5 days of workshops with a broad range of stakeholders and beneficiaries. And in the picture, you can see we used drama to investigate children's lived experience of air pollution. And this isn't just a tick box. This is really to ensure that the research is what the community want and is going to be done in the way that's right for them. So it quickly became clear that we needed a really robust sensitization program. So we secured some public engagement funding from the Wellcome Trust, and this facilitated us to roll out a significant amount of sensitization. So we started off with a co-design workshop working with our community champions. And these included local artists and musicians, and we devised some sensitization outputs that would work for kids. And we piloted these activities in December at a Santo in the Ghetto event outside one of the study schools. So I'll just run through some of the sensitization that we used. We used visual arts. This is a stimulus for discussion, but also is actually a research tool in itself, and we used it to research children's lived experience. We used games to help children understand the research and the importance of the research. So for instance, the Burst the Balloon game demonstrated lung capacity, measuring lung capacity. And we used music, and the great thing about music is the rhythm and the repetition in the song really helps to make the messaging very memorable. We used drama to show children exactly what would happen if they took part in the study. And we had our puppet, Billy, who was our example research participant. And we delivered parades and events in the communities and in the Tupamui schools. Then we had COVID, so the whole project paused for 12 months. And when we came back, we had to redesign all the sensitization outputs. So we literally redesigned everything, including the logo, and wrote new protocols for the activities. And this actually became an opportunity to promote some COVID safe behaviors as well. So here you can see a mural which shows people wearing face masks. A music video, again, promoting hand washing and face mask wearing. Even Billy wears a mask and sanitizes his hands as part of the data collection process. And the success of the sensitization is really evidenced by the recruitment. We hit our recruitment targets and we tested over 2,000 kids. We did some sort of more formal evaluation and the kids did report being knowledgeable about the project and keen to participate. And they knew more, interestingly, they also knew more about lung health in general. And field workers reported that kids would come in to the data collection saying, oh, this is what Billy did. You know, oh yeah, I know the song. So the key findings were that there were high levels of pollution in Makuru and Buruburu, both higher than WHO limits, but this was worse in Makuru. Higher levels of respiratory symptoms in Makuru, and the symptoms were more severe. And actually, a lot of children in both communities had asthma symptoms, but they weren't being diagnosed and treated. We're now disseminating the results back to schools, communities, and policymakers using comics, films, and talks. And my recommendations are embed participatory approaches right at the start. Use arts-based sensitizations. They're really inclusive. They break down hierarchies and make sure you co-design your sensitizations with trusted local champions. So I'd like now, thanks to everyone involved, especially our champions, and I've got 2 minutes to play some video. So if you wouldn't mind hitting play. Yeah. And this will really show you everything that we do.
It's emoji on the beat.
Feel free to dance.
Maisha marefu, tupumue hewa safi, maisha marefu.
Ya, pumua fiti, ishi fiti, maisha fiti, na riziki. Thankful imekuwa ngori, na hakuna mtu wa kututoa kwa bori. Labda Holy Spirit atutoe kwa ngori, ili tuishi hii maisha bila bori. Pumua fiti, ishi fiti, pumua fiti, ishi fiti.
Pumua fiti, ishi fiti, maisha bora wazee kwa vijana. Pumua hewa safi, fanya kazi kwa bidii, wazee kwa vijana. Pumue hewa safi, maisha marefu. Wasafi maisha marefu.
Come on, let's join hands too. Run down all these NCDs. Come on, let's join hands too. Decrease this immortality rate. Pumua fiti, ishi fiti, maisha fiti, 50-50. This a wake up call, don't get comfortable. This a matter of concern, sit down around table. Tunataka tujue nini mbaya na lanza Mwafrika. Watoto wanakufa wakiwa wayana. Bigger percentage problem ni la. Come on, let's join hands. Decrease this immortality rate. Come on, let's join hands. Run down all these NCDs.
Na nyumbani, barabarani, hata shuleni. Wazazi kwa watoto, tujilinde.
Brilliant. Yeah, when she was speaking, I was thinking of Kathmandu, which also need similar kind of intervention. Now I invite another speaker, Gertrude Banda.
I'm shorter. So my name is Gertrude. I work for the Malawi Liverpool Wellcome Trust. I'm a Global Health Bioethics Network Fellow, and I'm a registered nurse midwife by profession. So I conducted a study on participants' understanding of their roles and responsibilities in clinical research. This research setting was in Blantyre and Chikwa district. These are districts in the southern region of Malawi, where there are a lot of clinical trials and studies going on. So later discussed in literature responsibilities of research participants. We have standard international accepted standards for responsibilities of principal investigators and researchers, but rarely does literature discuss what responsibilities of participants are when they decide to take part in research. So volunteers' understanding of their role in research it appears to lead to different interpretations of their trial task. So participants that understand and know what is expected of them as they're participating in the study may be more assertive and protective of their rights and the rights of those others that are also participating with them. So this was a cross-sectional qualitative study. We employed purposive sampling of both host studies and participants. We used a thematic content analysis and framework during our analysis. So we had IDIs with participants participating in clinical trials. We selected participants with a pathological condition, but in clinical trials, and those that are healthy, but participating in clinical trials. And we had some that were just participating in social science research. We also interviewed frontline research staff, research nurses and field workers, and also we had interviews with principal investigators. We had 2 focus group discussions with participants in clinical trials and those that were participating in non-clinical trials. Results. So participants, we started asking about the motivation to participate in research. So participants participate in research as an opportunity for help. They participated to access quality medical care by participating in research. It was in exchange for quality-driven care. So sick participants felt they were helping researchers by participating in research in exchange for quality-driven medical services, while healthy volunteers participated to satisfy their curiosity and gain insight into processes and practices of medical research. On responsibilities, participants emphasized relational responsibilities, building relationships and maintaining them, not to disappoint or to let down staff conducting research, and they emphasize their role in helping researchers achieve their objectives, encouraging others to participate in research, and helping dispelling myths surrounding research. In contrast, researchers drew on those relationships that were created to promote functional responsibilities of these research participants. So they emphasize on understanding research, commitment to study visits, and all study processes, and usually driven by the study design and the study protocol and their role as study representative. So the results showed that there is an apparent disconnect in understanding of responsibilities when researchers said the responsibility of participants depends on what these participants are taught. So it means responsibilities vary depending on study design, setting, and the requirements of the study. And while participants think their role is to participate in research, get an understanding and insight, and then encourage others to also come and participate in research. So the process, how we did this research, as you can see, it's a very difficult topic. It was supposed to be, the study was supposed to be invested in it was supposed to be hosted because wanted participants were currently participating because of issues, of ethical issues of participant recontacting. So we had to use participants that were already participating in research studies. So we had ethics application, both local and international studies. We had collaborative consultative meetings with prospective host studies to accept us, and potential participants were given the leaflet for 7 days to read, because in our setting, you can, even if you are ordered to make your own decisions, but significant others have got a role to play in accepting or allowing you to participate in research. So we did coding and content analysis. We've developed themes, reread and reflected on them, and then we came up with reflexive memos. It was a very coming up with reflexive memos was a very important part for this study because of the type of researchers that were carrying out this study. So the recommendations, we recommend that there is need to emphasize rights and responsibilities. We can not only talk about responsibilities of participants without informing them of what their rights are. Community meetings, we suggested that participants need to be aware of their responsibilities before they meet researchers. At least they know what a researcher is supposed to do, and they're also aware what they're supposed to do before they decide to join research. Also, they should, a researcher said they need to be standard statements that can guide them to know what responsibilities of these research participants are, so that they're informed before they come to join research. Challenges, the data sharing questions that came in. We faced this one, information sharing with host studies. There were discussion as to how much information they can give us for participants that wanted to enroll in our studies. So we agreed that the host studies research team should, we started finding research studies that had consent forms with statements stating that those participants can be recontacted or invited to participate in other studies. So we had to check those studies first. And after that, we had to ask the study team to help us inform the participant that they will be contacted. So what they could give us was only the phone number. We called and got the names on our own. Co-recruitment was also a challenge. So what we did was recruiting a participant towards the end of their study visits in that host study, so that we don't have this problem of co-recruitment. Working within other people's projects was also a big challenge. As I've said, we didn't need to burden the participants with visit information and everything. So we had to really delay our recruitment to allow them finish the studies they're working on. Getting researchers, there is a lot of researchers in here. It's very difficult to get principal investigators as research participants. We had to work by their schedule. If they're saying I'm busy, I can't. So some interviews were done online. Some we had to travel to their offices to have them participate in our study. So in conclusion, so the motivation to participate by SIG participants raises ethical concerns of the possibility of being vulnerable to undue inducement, and then the difference in perception of participants, responsibilities between researchers and frontline workers needs aligning through engaging research staff as well, because we just say community engagement, but research staff also needs engagement. So researchers should also focus on how best to communicate responsibilities to enhance awareness and achieve mutual understanding. I hope I haven't been very, very fast. So acknowledgements. Those are the supervisors, and also grateful to participants and staff who took part in the project, colleagues and fellow GHBN at MOW and GHBN fellows. I can see a lot of them in here, and also the Global Health Bioethics Network for funding the project, LSTM for being the sponsor, and MOW for hosting the project. Thank you.
Thank you. Thank you, Richard. Yeah, very interesting perspective from the research participants' point of view. Now I invite Bartholomew Wilson from Liberia to present his paper.
Thank you. Good afternoon to everyone. And thanks to my colleague who earlier lighted up this place, because I felt like everybody was kind of falling asleep. But thank you for the opportunity. I am from Liberia, and on behalf of the Prevail team, we will be sharing with you our experiences of how we can promote research equity and participation through community engagement. And we'll be looking at particularly the INVITE study that was conducted in Liberia. So just to give you a little background, right around the end of 2020, WHO kind of issued a validation of using COVID-19 vaccines in emergency response. Few months later, about 3 months, Liberia got the first consignment of vaccines thanks to the COVAX facility. And those were 96 doses of vaccines. But then it took additional 1 month to actually roll out vaccination because of logistical issues that we identified earlier on. What we did not identify and did not appreciate were some of the structural and systemic issues that existed. The INVITE study was launched in August. And by the 23rd of August, we have started enrollment of participants. So the INVITE study is an international collaboration with multiple countries. The aim is to look at the immunogenicity and the durability of vaccines in people who have been vaccinated either with an initial dose or a booster. And we all know this was happening right around the time we had the emergence of the Omicron variant. And so it was very important for us to also look at breakthrough infections. In Liberia, the study was conducted by Prevail, and in other countries, you have different partners implementing the study. But during the early enrollment, this is what we observed. We observed gender discordance. Although we did very well, in less than 1 month, we had already enrolled over 200 participants, but now you can see 62% of those were all males. And we really wanted to understand what was happening. And this is where data sharing became important. We went back to the Ministry of Health and showed to them what we saw and asked if they could share what they had seen from the vaccine uptake. And interestingly, there was a pattern there. The Ministry of Health also realized that at least 64% of those who were vaccinated were all men. So then it became more interesting. And we decided to do what we should have done from the beginning, rather than making an assumption that women, are always exposed to vaccine. It would be easy to get them vaccinated and get them to enroll in the study. We should have talked to people. So we went back to the communities, held engagement with the leaders and the women group, and they told us, for us to successfully implement this study, you need to engage people in smaller meetings. You need to listen to the women, listen to people's concerns and what the challenges are. So these are pictures from some of our engagements that we held. And at the far bottom, you'll see our PI talking to people on the radio who have concerns about COVID vaccines and trying to address those concerns and fears. So we learned from all of these engagements there were barriers, and those barriers were not necessarily as a result of hesitancy or vaccine oppression, as we always believe. There were barriers about inadequate information, barriers related to limited accessibility. Vaccines were at certain health facilities, and women being care providers did not have the time or opportunity to go to those facilities to access the vaccines. So we decided to do a pilot project, and instead of asking people to come and get vaccinated at those facilities, we will now take the vaccines to the communities, have engagement with people, listening to whatever concerns or fears they had, and then people got vaccinated. So 95% of those we engaged at the community level enrolled took the vaccine, and 76% of those who took the vaccine enrolled in the INVITE study. 76% female enrolled in the INVITE study. So you can clearly see the difference there. Between August to September of 2021, you see female participation is very low, 34, compared to October to December when we started to do these initiatives. You see clearly that it has gone up to 56%. And then the Ministry of Health realized this was very important and helpful, so they decided to kind of adapt this process. They set up a mobile team that was now taking vaccines to the community and talking to people and answering their issues or whatever questions they had. And that helped to improve the national vaccination rate, not only in our study where we increased female participation to 45%, but also at the national level. Now the women vaccination rate among women is 49% compared to when we earlier started this study. And we can say it is only because of what we did, but we clearly see that there is a value in doing such an engagement and making sure that we meet people where they are. So just to share with you some of the recommendations that we are proposing based on what we have learned, it's important that we look at gender-based barriers. Okay, women have specific needs. They are mothers. Sometimes they're at home. They don't have the opportunity that we may have the kind of information that we have as men. And so it's important that whatever research or public health intervention that you're considering, you have to take those values, those concerns that are specific to women, take them into consideration. Pandemic response must consider the gender context. It's not every size that fits all. And what is also more important is the messenger. Sometimes we have these messages that are important, but who is bringing these messages? What is the role of women in communicating health messages and getting other women to be part of research? Low uptake is not necessarily as a result of vaccine hesitancy. There are other structural and systemic issues that we have to deal with. And until we do that, we may not be moving forward. And the way that we can do it is through community engagement. And what I call community engagement is one that has the value of respect, one that is built on the learning from experiences and the views of people who are affected directly, and one that is accountable to all stakeholders. We as researchers, we must realize that we are accountable to our stakeholders and we must hold them in high esteem. Also, trust is very important. There's no way you're going to be successful in research without gaining the trust of your stakeholders. And the way to gain that trust is get them involved right from the beginning. And when we do that, we're going to be successful in our research endeavors. So thank you very much for this opportunity and for my participation.
Thank you. Thank you, Mr. Wilson. Right on time. So 25 seconds more we have. And providing us a very impressive example about how to address gender equity gaps in vaccination through research and intervention. So now I request our last but not the least, Angela Carlo, to present her experience in Kenya.
Thank you. Thank you. My name is Angela Chalo, school program, school engagement program lead, KEMRI Wellcome Trust, Kenya. I'm talking about embracing agility in the time of COVID-19, the case of KEMRI Wellcome Trust engagement program, Kilifi, Kenya. So a brief background on how the school engagement program evolved. It came about from the bigger KEMRI engagement program, where the community members requested for a school engagement program where students and the youth can have an opportunity to experience science and a kind of information around science related careers. So we piloted in 3 schools just to understand what the students will want to experience, and also the kind of activities that we can really manage with them. And after a year and evaluation, we felt we had got it right, and we got into 5 more schools where we had students coming to the program to have experience with our lab facilities, engage with scientists. And we introduced something called the School Leavers Attachment Program, where the Form 4 leavers had an opportunity to come to the program for 3 months, interact with sciences, understand the various careers that the research institutions have, whether science or not science, how such careers intertwine in the area of science. So that happened for around 3 years. Then we expanded to 30 more schools. And this time we felt we needed to have deep and wide activities. Deep in the sense that we had a few schools, 10 of them, that we engaged very closely to have close interactions with the students almost several times in that term. Then we had wide activities where we had to engage more schools, around 20, with one kind of an activity to reach further and still have give them a feel of what we do as a research institute. Then we further again expanded to 39 more schools, and this time we introduced an online platform where for the schools that we could not reach physically, they still can have an engagement with us and have a feel of what to do as a research institute. Then during that time, that took up to 2020, 2016, 2020. Then COVID happened and there was interruption of the physical activities, and focus slightly shifted to preparedness and a response. However, this was also a time for us to explore the virtual platform. We felt we still can reach out to students through online engagement. We consulted widely because this time we could not just work with the Ministry of Education. This time consultation had to go further with the Interior Coordination Ministry and also the Health Ministry, which was the key partner when it comes to COVID messaging. Then we had a consensus building the teachers to ensure that the activities that you're going to undertake through the online platform are relevant to the students in line with the curriculum they are doing. And we're also giving the students a live experience or a relevant experience with their lived experiences in health and health issues. So this time, this is when we decided to have the online sessions. We piloted again, this time within 3 schools, and we felt we were able to cope, the students were able to cope, although amidst a lot of challenges, technological, of course, both the technological infrastructure and skills among the teachers and the students. Even so, we had to have time and opportunities every time we have a session just to make the teacher and students comfortable to use of technology. Again, the schools had to be few because, again, the facilities were also strained and connectivity was an issue within the school's environment. So our approach was literally participatory process through planning meetings with teachers, contact teachers, and education officials. And implementation happened through essay competition that was done virtually, and among others, school science symposium. And we had feedback sessions with teachers, evaluations with contact teachers and learners just to understand what their needs are and whether we are meeting them through the virtual processes. This is one of the session that we had among the main sessions that we had with students. And through this platform, we had career talks in 10 schools. We did have the young persons advisory groups that we did virtually for these schools. And then we had an essay competition that we conducted among 19 schools, all the way from instructions to the writing, to the marking, and to the award was done online. And there was a mixture of virtual platform and remote activities where we used a comic book just to reach to the primary schools on awareness of the sickle cell anemia. And we had a sessions on question and answer with scientists for students to get to ask questions on issues about health and the different kind of information that they required on prevailing health issues. So the key challenges we had restricted access to schools, limited access to ICT, tight schedule calendars, and uncertain policy environment. Those are the results that we got, like I said, but we realized most of the engagement was with the secondary school and the university, partly because they could comfortably use the technology. And therefore we felt some of our conclusions and recommendations that leveraging on technology is essential, is ensured, it ensured continuity in school engagement, even though it was not very effective in some of the schools due to limitation that they had, but we still had engagement with them. However, a blended approach works better, where we have a mix of remote working, virtual platform, and some physical kind of engagement. And then adopting co-planning with teachers ensured that the relevance of the material and ownership among students and teachers is assured to ensure sustained interest and engagement. So this one we worked with KEMRI, all the KEMRI team, especially the KEMRI Wellcome Trust School Engagement Program team, and of course the funders with Wellcome Trust and a collaboration with Oxford University. Thank you.
Thank you, Angela Chalu. Now we have heard all the speakers, and the remaining time I have planned in this way, in order to say, we have to have a photograph also. I'm sure you are bubbling with questions. Therefore, I thought I would skip the chair's remark. The speakers were so clear about that. I don't have to summarize about that. But what I'll do is maybe about 5 minutes for question answer. Any burning questions we'll take, and then some kind of a take-home message for you from their own experience. I'll ask one question to answer, get answered by all the speakers. Okay. So the first 5 minutes is if you have any question to any, including the plenary speaker, you know. Okay, I see one hand there, 2, front, 3, 4. Okay, the first 4. That's the limit. Wonderful.
Hi.
Yes, you please. Can you identify
Is it
yourself?
audible?
also?
Yeah. I'm Jason. I'm from India, the George Institute for Global Health. So it was all nice presentations here. in
Yes,
the-
we can't hear you properly. Can you come near and speak? More near, yeah.
So it was all nice presentations, hearing the community engagement and the participatory kind of like managing the epidemic. So my question is to Dr. Mata. So you have mentioned the 3 principles, and the second was the decentralized governance system with 3 tiers of with municipalities and the state at 1 and 2. So can you briefly mention what was the role of the decentralized governance system in this community engagement? So was there some kind of like multi-sectorial mechanism or interdepartmental coordination? So just
This one, what I should do, I think, let's take the one more question and then see whether you should respond first or not. Yeah, I think you are the second. Yeah, please, can you bring the mic here? And then Alia. Yeah, front.
Thank you. I am Tani Sanya from Burkina Faso. And I just want to share a little thing after the speakers, Edouard and Wilson, about COVID hesitancy, COVID vaccination hesitancy. Because we conduct a study like this to check the factor influencing this acceptance of COVID vaccination. It was a study involving 5 countries: Burkina Faso, Guinea, Mali, Senegal, and Sierra Leone. It was sponsored by BNITM in Germany. So in this study, we found that the effectiveness and the safety of COVID-19 vaccine increase the willingness to get vaccinated. So communication strategy about safety and effectiveness of vaccine is the basis of any vaccine acceptance. This is what I want to share. Thank you.
Alia, please.
Those were excellent presentation. My direct question to our colleague in Uganda, you worked with the prevention of teenage pregnancy in involved males in the community. So I'm very interested to know what challenges you have faced and how you overcame that. Thank you.
Yeah. So my question is to Dr. Boyer. Really interesting presentation. We would like to hear that song at the end of the conference again. But I was just interested in, once you'd imparted the knowledge, what was the actual actions? Because in many of these places, for example, Mukuru, there's a lot of socioeconomic challenges in actioning. So it's nice that they are more aware, but for example, how do you change the fact that they live in a very dilapidated environment? They are cooking with, charcoal and things like that. How do you move them from just knowledge to then actual action? And I'll be interested to hear what actions were happening beyond the knowledge. Thanks.
Hello, my name is Rubina and I'm from Pakistan. My question is directed to, I'm sorry if I pronounce your name, it's very difficult. I'm still trying to pronounce it right. Bartolome, I'm sorry. Yeah, I'm sorry, my question is directed to you. There will be a 3 question, but I won't take much time. I executed the same study in the tribal Pashtun area of Pakistan. So I face a lot of trouble when the women were very resistant, even they were not opening up why they have the vaccine hesitancy, but it was very difficult for me to open them up for the, when I was conducting interview. First, they open up and then they were very hesitant for co-design approach for designing intervention. And then it was very hard for me to generate the demand of vaccine from women. So my question to you, what challenge you faced when you see the women vaccinations uptake was low? How you opened them up to speak of hesitancy? And who was the trusted person when they convey the message to a woman about the vaccine that you can take this vaccine? So who they trusted the most in your community? What strategy you use them, what strategy to open them up to speak of hesitancy? And if they are open up for the vaccination, how you address the inequities and make the vaccine accessible to them? Because we face this problem. Yes, sorry.
Okay, thank you very much. The questions are long, but you have 40 seconds each to respond to it. Okay, so who is the first to respond? I'll be looking at the watch. Yeah. Who is the first to respond of all this? Okay, you want to speak? 40 seconds. 2 sentences.
All right. Thank you. That's a very good example, and thank you for your question. I think what we try not to do is to go in the community and create the idea that there was vaccine hesitancy. No, we didn't try to do that. We worked through the structures and we pretended like we knew nothing and asked them, like, we are having this challenge. What do you think is causing this problem that more women are not getting vaccinated? And they came up with their own suggestions and their own solutions. Okay, in terms of how we open them up, we use the women leaders who were influential in the communities. They called them to the meetings. We just, were there as facilitators, but the women were leading the discussions. And then that's how they opened up and they started to explain what their challenges were, what the barriers were.
Okay.
So how we overcame those barriers, the last one, is that we took the vaccine and the research to them rather than having them come to the facility where they feel uncomfortable and they think that the questions will not be answered properly.
Thank you. So who's the second speaker responding? Yeah, please.
Yeah. Okay, so my question was around male involvement in teenage pregnancy, what the challenges we faced and how we address them. So first and foremost, Uganda is a multilingual kind of country. I think we have approximately 52 languages within the country. And well, some you easily understand, but others are really so far disconnected from each other. So where we are based, we are within the central part of the country. So we are more familiar with Luganda, which is like probably the biggest tribe within the country, and English. But the intervention, the group we are working with comes from the eastern part of the country. So we had to get someone from that part of the country who speaks that language, and we go through that person with the evidence that we've compiled together, ensure that when this person is talking to these people, he or she is adequately representing the evidence as is or as we intend it to be. Then second is the context. You find that if you read literature, they'll tell you keeping boys busy is one of the ways in which you can avert teenage pregnancies. But when we went to have conversations with the boys in the field, it was quite interesting. The boys told us, you keep us busy, we get money, we shall chase after the girls. So it becomes really complicated. So you're going to have to think about context, and actually the interventions become very context specific for whichever region you're going to. So that is the other thing that probably we have to keep in mind.
Thank you. So it's finished now? Or any questions left to be answered? Yeah, I have. Okay. please. You can use this one.
I think my question was around action and change and creating impact. So I'd just like to talk about two things really quickly. So one is around the undiagnosed asthma that we found in both communities. So we've already had some discussions with the Ministry of Health, who have indicated on camera that they will be setting up some extra clinics in both those communities to diagnose and treat the condition. We also are aware that some children, because the problems were identified as part of the study, they've already gone to their doctor and said, look, I think my child has got asthma, and they've been diagnosed and they've been treated, and their quality of life has improved as a result of that.
Thank you. Sorry.
And then just briefly to talk about the air pollution sources. I didn't talk that much about the results of the study because that's not what I was here to talk about, but we identified so waste burning, mosquito coils in the home, smoking in the home, and traffic, which is something a little more difficult to address. But so the next step in terms of that is, you know, the community are already galvanized for change. So we can do things like raise awareness around waste burning. We can try and make sure that it happens away from homes. Mosquito coils could be replaced with mosquito nets. And we have produced some really nice 30-minute documentary film that we will be using at all different levels. We'll be using it to try and get more funding. We'll be using it to try and inform policy. But it's interesting because the community engaged, the community are going to be more applying a bit more pressure to make these changes now that they've been part of the research and the evidence.
Okay, thank you so much. Now, Gustavo, your turn, I believe.
Yeah. Well, very quickly. So if I understand well, your question is about decentralization and intersectoral work. So I could include another dimension that's about also on social participation. So we have during 2000 an important program that we call Family Grant. So it's a minimum wage program with a lot of conditionalities, right? So, but it's completely decentralized, the funding from the federal government, and then you spread the funding with a lot of conditionalities with school, vaccination, immunization, to have a primary health care coverage and many other things. So one thing that I would like to highlight in this point is after COVID-19 impact, I think that we have to rethink everything, right? Because COVID-19 impact has a very multi-sectorial impact. We have impact in education, we have impact in terms of the gender violences and many other things that after the beginning of COVID-19, in the very beginning, we start to talk a lot about inequalities in science, inequalities in social problems, in vulnerable populations. But after immunization and vaccination, it is still important. We only talk about immunization coverage, right? We are not talk anymore about the impact of COVID-19 in a multi-sectorial dimension. So this is an important ethical issue to be discussed in local and global level.
Thank you. Thank you so much, everybody. And, you know, for the sake of timekeeping, I'm cutting down that common questions and, you know, take home message also. I hope you can interact. And you people were so clear, and there are many take-home messages people are already taking from this hall, I believe. So what and forgive me for being so brutal, because I had to maintain that time. And I invite Professor Reader to, you know, say his words and probably conclude the session. Thank you.
Hello again. We're getting towards the end of the day and everybody's very tired, but I've been tasked with summarizing the day. You'll be really glad to know I've kept it down to around 50 slides. You weren't doing anything this evening, were you? No, of course, it's been a really rich day of fantastic presentations, and impossible to go into this in any kind of detail. But let me just pick out one or two of the things that have struck me. Firstly, fantastic panels, fantastic plenaries all through the day, and congratulations. And let's give another round of applause for all of the speakers today. We've actually covered the entire research process, from building research teams, enabling research in every healthcare setting. We've been hearing about community engagement. We spoke about putting evidence into policy. So we've really closed the research circle during our discussions today. But what struck me was the really practical sharing of experiences, and by speakers that were not only from the academia and researchers for academia, but a broad spread of people using research as tools in their work. And I think this brought a really different skills, different perspectives, and gave the day a real world feel. It really felt like we were tackling the health issues out there rather than sitting around discussing academic methodologies or wording on these things. And I, for one, was really inspired by this approach. I thought it was just terrific, and it's given me much food for thought and thinking about how TGR can make sure it's supporting this kind of research into action. We really need to continue this journey to decolonize and to democratize the science. And I think that's what we've been seeing today. We've been seeing this being discussed. And I really applaud the Global Health Network for bringing us together for this challenge today. It was a real privilege to join you. And all I can do in finishing this very short talk is to quote Walter, one of our earlier panelists, and say, rise up and spread the gospel. So have a great evening. And I think Trudy's got a few comments to go.
Thanks, everyone. Actually, I've just got housekeeping, because it's time for us to go and have some fun now. But what a great day. Thank you, everybody, for your taking part. So some really simple housekeeping stuff. And we're going to have a photo, which will be really good fun. And look, the sun's come out for us. It's just the best setting. So when we finish in a second, I decided we needed an encore from your music, Cressida. So as soon as I finish talking, we can all leave to your music. So feel free to move out in any way you like, because it was so good, right? So we're going to have an encore in a second. So when the music comes on, process, dance, whatever you want to do out onto the steps. Then at 6:15 prompt, the buses are going from the South Car Park. So hopefully most people are coming on to the dinner and we can do some more dancing. And then if you're not, the buses are going back to the hotels. Now, tomorrow morning, we've really managed to keep to time today. So thank you. That was just, we had so many speakers to fit in. The timing was absolutely vital. So tomorrow we're going to do the same again. So everybody come tomorrow, please. Let's keep the attendance up too. We've got some brilliant sessions again tomorrow, a really different one in the afternoon to finish us off. But we're starting with a very special event with the WHO team leading that at 8 o'clock. But we've got an amazing breakfast. We're all going to be up baking all night for you. So come early, have breakfast together, talk some more, and then be sat down in here at 8 o'clock sharp. I know it's early, but we can cope. Cue the music, photographs, bus, 8 o'clock in here tomorrow morning. Asante sana.
Sing. It's emoji on the beat. Tupumue hewa safi, maisha marefu. Tupumue hewa safi, maisha marefu.
Pumua fiti, ishi fiti, maisha fiti na riziki. Lung problem imekuwa ngori na